All right, we are back with Doctordle, the one game that keeps generating views on my channel for some reason. Hello everybody. Yeah, I made a post on my YouTube channel the other day, or I think it was yesterday. I made a post yesterday, and I pretty much just asked like, what do you guys want to see me do more of? And I guess originally when I started this YouTube channel, I wanted to do more like individual educational videos about like certain conditions. And when I ran the poll, I basically gave two options, like, do you guys want to see more of those, or do you want to see more videos where I'm like working through medical problems and like trying to, determine what a diagnosis is? And I guess a bunch of people just like watching me do do board review or play Doctordle for some reason, which I'm not judging you guys. I just didn't think that would be popular. Like, why is this interesting to you? I don't know. But like when Conan came to my stream last week and like talked about making a video about me, that video he made about me like popped off really hard. And he was just, going through different things like, oh, I wonder what his audience is. Like, I don't think he tries to reach to like med students or residents, but he's not like super broad, like a full layperson audience like someone like Dr. Mike or Chubby Emu would. So I guess I kind of hit somewhere in between, right? I mean, it's VTuber watchers, right? Most of you probably like late teens, 20s, maybe like early 30s, right? And you're just curious about medicine, right? There's a lot of stuff going on in your life, right? Maybe your parents are starting to get diagnosed with stuff. Maybe you're starting to get diagnosed with stuff. And it's just important to know about different conditions that might affect people in their daily lives. And yeah, so I guess besides doing those short videos where I talk about individual conditions like, I don't know, diabetes or like hypothyroidism, what really gets the views on this channel is me doing questions about these conditions. So today I present to you doing as many Doctordle questions as I can in one stream until I get one wrong. So we went from American Board of Internal Medicine board exam level questions down to Doctordle. Right, so Doctordle is definitely developed more like a med school level. I didn't actually know this, but if you go to like the meet the team part, I mean, they do have all of their bios, and most of them are like med students themselves. So, and like in the more recent Doctordles that they have, like after you get the question right, you can like link it to Anki, and it has like integration with with this flashcard app that a lot of medical students use. So to be honest, like it is a very med student facing resource, definitely really good for things like step 1 or step 2 CK. So it's not difficult in the sense that it's like difficult to diagnose as like a board review or like a board exam kind of thing. It's like Wordle, right? They just give you hints. So there is a chance that this stream ends in 5 minutes, and there's also a chance that the stream ends in 5 hours. But we'll see. What happened to the house video game playthrough? Oh, I looked at it, and it's not really like a medical game at all. Like it's not like a visual novel. It's really just like a house episode with like Professor Layton puzzles in it. And I was like, this actually probably isn't that interesting. Like you're literally just playing through a house episode. And I was just like, well, I could do that, or I could just play Doctordle because this is apparently what the people want. Oh, that's so cool. I did not know that. Yeah, this is a pretty new one. So if you go back to like the first 100 Doctordles, like I doubt they have like the Anki integration and everything, but it's like the more recent ones definitely do. So yeah, you got this, trust me. All right. So there are a bunch. There are 354 of these that they've done now. And I've done a few. So you can have Doctordle accounts now, which is pretty cool. So it saves your progress across devices. I definitely remember doing most of these on stream, but there is a big chunk here that I didn't. So I've done 1 through 33. And then I remember when I had Bree and Hazumi do like the Can VTubers solve Doctordle, we started at 6-7 because, of course we had to, right? So I'm willing to start at 34, and then once we get to 6-7, remind me to skip over to 78. But we will do our best. 6-7 was mandatory. Yeah, of course. Of course. We started with Bree too, so of course we had to start with that. All right. I'm not gonna give myself like a time limit or anything. I don't know. I mean, Doctordle, it's okay. I don't not find Doctordle fun. It's just more like frustrating because it only gives you so many pieces at a time. Like I think like it's more fun to do board questions for me just because it's actually like things that I've like studied for presented in a way that I've studied for, whereas like Doctordle is like things that I've studied for presented in the most backwards ass way possible, where they slowly drip feed you the information and you can get it in 1, you can get it in 6, even if you still know what the condition is at the end of the day. So all right, it is time. Let's get started. So Doctordle number 34 from August 19th, 2025 asks you, a 24-year-old female patient presents to the ED with severe epigastric abdominal pain for the last 24 hours. So for the last 24 hours means that this is a pretty acute thing. Epigastric means that it's going to start upper in the stomach, right? So you're really, thanks for the super chat. Epigastric means that you're more like in the upper stomach area, centered around kind of like the middle lower part of the chest. So definitely not really area for appendix, not really the area for like ovarian cyst. Epigastric abdominal pain. So this could, again, it can literally be anything. In before something wild like Mallory-Weiss tear? No, you can literally go ahead. Mallory-Weiss syndrome, right? I mean, it's Doctordle. We'll eventually get it in 6, right? Like there's no shame in getting it wrong after the first or second one, right? So, she reports that she recently started a new birth control and weight loss regimen. Okay, so now we're worried about kind of like drug-induced reactions, or weight loss regimen is another one too. So I guess with weight loss, I mean, this is just super out there, but weight loss, you're also thinking of things like mesenteric ischemia. There is a thing where patients lose the abdominal fat pad that's basically holding up the superior mesenteric artery. And once you lose that fat pad, you can get ischemia because your blood flow through that artery is impacted because the angle is too shallow. I don't know. Anxiety, of course. She's a 24-year-old female. Of course they would give you anxiety. I mean, I don't even know where to start with. So birth control and weight loss regimen, like I kind of started yapping about that SMA syndrome thing first, but I'm kind of thinking like drug reactions, right? I mean, new birth control with new epigastric abdominal pain for the last 24 hours. Pancreas, right? Yeah, it could be. Birth control falls under, I guess it would fall under like the drugs section, right? So the full mnemonic for all the different causes of acute pancreatitis is I get PP smashed, right? So it's idiopathic, it's gallstones, it's ethanol, it's trauma, it's P being pancreas divasum, which is very stupid. The other P is going to be posterior duodenal ulcer. PP smashed. You're also going to have like scorpion sting, but the scorpion like only lives in like Trinidad or something. M is, oh crap, what's M? Oh no, how did I forget it already? That's like my favorite mnemonic from med school. Oh, what's M? All right, I'm gonna skip. Oh yeah, mumps, right? That's how you know that I'm an internal medicine doctor, because I just like never encounter that. And then you're also worried about what is the other one? Alcohol? Addison? No, did I already say alcohol? Oh, I said ethanol. Alcohol. Wait, steroids? No, it's A is next. SMA. You know what? Fuck it. I'm just gonna look it up. okay. It's I get PP smash is idiopathic. Guys, I forgot about the I. It's idiopathic, then gallstones, ethanol trauma, posterior duodenal ulcer, pancreatitis dewisum. S is steroids, M is mumps, A is autoimmune, S is the spider bite / scorpion stings, which I already talked about. H is hypertriglyceridemia. E is ERCP induced, which is like we do a procedure to take a look and that injures the pancreas. And then D is drugs. So all of this is to say acute pancreatitis totally is in the differential. Oh my god, thank you for the jewels and stuff. I didn't know that I had sounds on for that one, actually. All right, I muted most of the stream alerts because a couple of people said that they found it annoying, but thank you for the gifts. I guess I can keep these in because I don't think jewels and super chats are going to be as often as like a Twitch sub or a follow, so that's okay. Honestly, pancreatitis could be a good one. Patient is tachycardic and hypertensive. Lab testing reveals mild hyponatremia. Bro, Twitch chat keeps talking about like for when I was doing board review last stream, like you have to rule out depression. You have to give them a PHQ-9. Let's see. Tachy and hypertensive. Lab testing reveals mild hyponatremia. I mean, I don't know. Tachy and hypertensive. Decreased motility, constipation. I'm thinking like a thyroid picture. I mean, there are very few things that make you tachy and hypertensive. Like, I'm thinking thyroid, maybe renal. Lab testing reveals mild hyponatremia, so I guess it's pointing more towards renal. But why would renal lead to epigastric abdominal pain? That's okay. Renal. Scleroderma renal crisis. Pain. Like the sixth clue is gonna be like patient also just got into a car accident. Let's see. I'm gonna say. Actually, you know what? Scleroderma renal doesn't have it. Pheo could totally be it. Pheo would present more of like with a headache, and I'm not really sure how new birth control and weight loss regimen would fit into Pheo, but yeah, so wide pulse pressures, tachy hypertensive, like this tachy hypertensive thing is throwing, so it's like I'm thinking thyroid, but also hyponatremia kind of points more towards kidney, but epigastric abdominal pain doesn't really cover thyroid or kidney. So I'm not really sure. How are you doing? I'm doing okay. I'm still streaming, which means I haven't gotten one wrong yet. Coincidentally, I haven't gotten one right either. Acute intermittent porphyria? Because it's lasts 24 hours? Actually, I mean, I guess porphyria kind of fits. Because it's like a drug-induced reaction from probably her new birth control. Ah, she has a clot from the OCP causing bowel ischemia. That's why I wanted to put SMA syndrome. Like she has like a thrombosis and it's causing mesenteric ischemia. Should I put AIP? Oh my god. Acute intermittent porphyria. Like, it's not wrong. How the fuck did you get that? How the fuck did you diagnose AIP off of that? Wait, okay. So, while in the ED, the patient begins to exhibit paranoid delusions and agitation requiring mild sedation. Further questioning of the family reveals that several of the patient's relatives have had similar episodes. Then I probably would have gotten it on these two. And then the last one is really just screaming. A urine sample collected turns dark after standing and testing reveals elevated porphobilinogen. AIP, I think it's in season 1 of House, I'm pretty sure. It's in season 1 of House. Like, it's House's ex, right? The lawyer, and they have to like diagnose her new boyfriend, and like House is jealous of him or something, but he's also having like the acute like paranoias and delusions and agitations, and then they diagnose it by like collecting his urine and then like shining it up in like a window or something. But yeah, beginner's luck. I don't know. I'm just saying. I don't know if I would have gotten AIP after the first 3. I mean, how bad is smoke, ash, and soot from wildfire to breathe in? Dealing with that is pretty bad. I mean, from a smoke inhalation injury, you're more worried about the stabilization part and trying to manage airway trauma and airway burns, which, if you're sitting here donating me a super, thank you, but, you know, well enough to be able to type that, I guess that part went fine for you. There are still plenty of different medical conditions that can happen down the line, you know, from the actual injury itself. So, you know, hoping you get better. It's in House, it's in Grays, it's in The Resident, TV's favorite boogeyman. All right, that one was a little sus. That one was a little sus. If you gave it to me on, I'm gonna say I would have gotten it on 4 or 5 anyway. I would have gotten it on 4 or 5 anyway, but getting it on 3, getting AIP on this 3rd clue is a little sus for me. All right. 45-year-old man presents with jaundice, abdominal pain, and fever. Okay, so we're working with gallbladder etiology, right? I mean, we're thinking we have backing up of the liver. We're thinking we have probably like bilirubinemia, something like choledocholithiasis. So this is when you have a blockage from the gallstone of the common bile duct. So not only are you having impaired bile secretions, but you're also blocking the bile ducts that come out of the liver as well. Which, you know, is not the right answer, but whatever. Cholangitis, yeah, they put choledocholithiasis and ascending cholangitis in the same one. So a right upper quadrant ultrasound reveals dilated bile ducts and intrahepatic cholestasis without cholelithiasis. Okay, well, I literally just put down choledoco, so I don't... What? Right upper quadrant ultrasound reveals dilated bile ducts and intrahepatic cholestasis. So this is saying that they did an ultrasound, they took a look at the liver, the bile ducts are dilated, which means that there is something downstream that's blocking it. And intrahepatic cholestasis, which means that you do have like kind of biliary sludge sitting in there without cholelithiasis, which means that there's no stones visualized in the gallbladder. But again, all of that actually kind of still fits into the picture of choledocholithiasis because your blockage is in the common bile duct, which is way downstream, which means that everything else upstream is being blocked. And I put down choledoco, so... Now we have to think of other things that can cause dilated bile ducts and intrahepatic cholestasis that's not choledocholithiasis. So we can talk about like METs. We can talk about, do they have Merizzi syndrome? Dude, Merizzi syndrome is so cool. It's like when you have Merizzi syndrome is like when you have like a gallbladder, like a gallstone in your gallbladder that's not blocking the duct itself, or no, it's a tumor in the gallstone. You have something in the gallbladder, either like a gigantic stone or a tumor, but it's so big it's actually causing a mass effect and compressing the biliary duct from outside the actual duct itself. So it's like it's literally pushing into something from the outside and causing the same symptoms as if it had an obstruction on the inside. Honestly, Merizzi syndrome probably would have been a pretty good one here, but they don't have it on the thing. When smoking is mentioned as a risk factor, is it specifically cigarette smoking or does that include marijuana? I mean, in general, if we're talking about like current research and how we attribute smoking with, you know, cardiovascular disease and increased risks of stroke, they are mostly talking about cigarette smoking. Cigarette smoking is extremely harmful from not only the tobacco load, but the nicotinic load as well. And yeah, you can extrapolate from that where if you're smoking marijuana, you're also inhaling fumes. If you smoke vapes, you're also inhaling nicotine. Most of the research right now is really about cigarette smoking. And there's going to be a bunch of other people on the internet that'll tell you smoking marijuana is totally fine, like vaping is totally fine. First, for my context as an internal medicine doctor, I would much rather have a patient like vape every day or smoke marijuana every day than smoke a cigarette or a pack of cigarettes every day, right? So that's where I stand on it. How do you think about tests with limited sensitivity? IRC for ultrasounds detecting stones is about 50% sensitivity. I mean, sensitivity, specificity, you got to think about, you know, like pre-test probability, throw up the normogram and everything. I guess I will say, remember what sensitivity means, right? So highly sensitive troponin is a very popular lab in a lot of hospitals, right? And a lot of people kind of forget what highly sensitive means, right? Sensitivity, like if you remember your stupid mnemonic from med school, spin, snout, right? Specificity, high specificity helps you rule in diseases. High sensitivity helps you rule out diseases. So ruling out disease with a negative value is just as important, right? How many times in residency was I asked to admit a cardiac patient for suspected ACS with, you know, 2 negative tropes, right? And a totally fine ECG, right? Like, it's like people forget what HS troponin means. Like, the S stands for sensitivity. Like, think about being sensitive. Ah! Somebody said, could this be PBC? PBC or PSC? So I think PBC is more associated with intrahepatic ducts, also like female, and then PSC is intra and extra. I don't think PBC could be wrong. I was more like thinking like what's the amoeba that makes like those liver paste cysts inside the liver? You know what I'm talking about? And I was thinking if you have one of those cysts and it's blocking up the ducts from the inside too. Chlornorchis? No, it's an amoeba one. It's a oh god, what's it called? Entamoeba histolytica. Yes, Entamoeba histolytica, right? So you have these like stupid okay. Lab testing reveals mildly elevated AST, ALT, elevated ALP, and eosinophilia. And anytime you see eosinophilia, you have to think about parasites. And I think somebody also said this in the chat, Chlornorchis sinensis, Chinese liver fluke, very famously has an eosinophilic reaction. There we go. I think this is this one's in Cells at Work. This one's at Cells at Work. When you meet eosinophil Chan, you know, she's the blonde one in the pink, and she uses like a pitchfork or something. But they fight Chlornorchis sinensis with a white blood cell, and that is like the GI tract parasite that you worry about for cholangitis. This also can lead to cancer too. So definitely very, very sure that you make sure to clear the infection with, I guess, praziquantel. He reports that he recently traveled to East Asia for an exotic fishing experience. As you can tell, Chinese liver fluke is probably endemic to China. Stool examination reveals oval-shaped operculated eggs. Operculated is such a good word. I would not know what to do with that at all. I probably knew that at one point, like second year of med school. But yeah, praziquantel is just like anti-parasitic. We would use praziquantel and, you know, drugs like albendazole. Other things you've probably heard about are like ivermectin, right? And these really help you get rid of parasitic helminth infections. Telling us the AST ALT is elevated when the patient is jaundiced is like saying water is wet. Well, one is talking about a transaminitis and the other is talking about a bilirubinemia. What's an exotic fishing experience? Don't you want to find out? Yeah, this one definitely doable here at the eosinophilia. Honestly, if my Entamoeba one was right, I would have gotten it in 2. That would have been so cool. But eosinophilia definitely, you know, red flag for parasites right there. You never see eosinophils unless it's like one is like the eosinophilic pneumonia, which is like almost like a chronic lung disease. It's like a reactive pneumonia from like, you know, construction workers or something like 30 years after they retire. But otherwise it's mostly just going to be there with parasites. The other one that you have to worry about is basophils. I think basophil also appears in Cells at Work. He's the dude that's like all dressed up like Shino from Naruto Shippuden, right? He's in a hood and he's got sunglasses and everything, and he speaks in riddles. That's because nobody knows what the fuck basophils actually do. Like I don't think we really have like a defined function for basophils, but if you see basophilia, that usually means that the patient probably has like some sort of leukemia or other like blood cancer that's causing basophils to just randomly appear out of nowhere, because otherwise like they just straight up don't do anything. What's the difference between AST and ALT? Oh my god, I definitely knew this from like a biochemical standpoint at one point. One is aspartame transferase, the other is alanine aminotransferase. The AST-ALT ratio, they're just two different liver enzymes, but the ratio helps you determine different liver pathologies, because they might just have different, like one will have more of an ALT elevation than an AST elevation, the other will have more of an AST elevation than an ALT elevation. So if you're thinking like hepatitis, right, comparing the ALT to the AST ratio, you would expect ALT to be higher than AST. If you were thinking like cirrhosis from chronic alcohol use, the AST ratio to ALT is going to be higher, or the ALT to AST ratio is going to be lower because the AST is much higher than the ALT. I might have said that backwards. let me just check that real quick. Hepatitis, AST, ALT. All right. I said it correctly. Good. Good. Delicious parasites. Yes. Nom 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 nom. Okay. What are we, 2 for 2 so far? That's pretty good. 68-year-old man presents with sudden onset severe abdominal pain. Kind of like this 24-year-old woman that presented with sudden onset epigastric abdominal pain. Let's see. Maybe we can do appendicitis. He's a little old, for his appendix rupture, but it happens. You can see an elevated number of eosinophils when the patient has a chronic allergy problem. Oh, yeah. That's true too. Grass allergy, chronic itching problem. This is probably when like if you show eosinophils to an internal medicine doctor, they think parasites, and if you show eosinophils to an allergist, they're like, hello, it's allergy. What? Yeah, appendicitis. Aww. All right. He has a history of AFib, but denies any recent trauma or surgery. Oh, wait. This one's definitely mesenteric ischemia. Yeah. Okay. So, like I was saying, you have your artery, your superior mesenteric artery, and if you do something that messes up that one artery, that artery supplies a lot of your GI tract. And if you mess up that artery, you're not going to be able to get blood flowing through that area, and all of them are going to start crying out and getting ischemic, and they're going to die. Hello, ND, thank you for the raid. So like I was saying, for SMA syndrome, where if you lose a lot of weight and you lose that that little fat pad under the SMA artery, it creates a very sharp angle on the SMA and it cuts off the blood flow. Somebody else in, I think, the Twitch chat was saying that if you have a blood clot blocking that artery and cutting off the blood flow, it'll also lead to the same symptoms. So the SMA is the superior mesenteric artery, supplies a lot of the mesentery. So this guy is basically having half of his bowel lose its oxygen supply, and that's where all of his symptoms are coming from. So infrequent, painful bowel movements, abdominal tenderness, pretty elevated lactate level that's showing that tissue is dying, leukocytosis, probably reactive from inflammation, and then the CT angio reveals an occlusion in the superior mesenteric artery. So this one just straight up tells you like, oh, his superior mesenteric artery is blocked, and you're just supposed to be like, yeah, it's mesenteric ischemia, though. Probably not able to get it in 1. 2, I don't know if I would have gotten in at 2 if I would have made the link of AFib to severe abdominal pain, but I think just because somebody else just talked about it like 5 minutes ago, that, pathology was still fresh in my mind, and I was like, oh yeah, sure. Lamau, nice. Non-occlusive mesenteric ischemia, also known as Klausnomy, happens without a mechanical blockage. Yeah, that's what I was saying with SMA syndrome. Or let me look that up. Klausnomy? This gives me a picture of a German baritone singer. Anyway, SMA syndrome. Yeah, so you have the angle, and if you lose the fat pad that's holding up the SMA, you end up losing that angle and causing the thing. Basophil was responsible for like half of my Japanese flashcards from watching Cells at Work. Really just triggered a bunch of memories of obscure words. You ever just study like for N4 and you realize that you just know like so many obscure kanji just from like watching anime and playing games? Like like you learn just like everything for N4 or you know whatever exam you're taking, and then you realize like oh, why do I know the phrase like seigi no mikata or like sonzai no chikara, or just like random like A of B or like X of Y phrases just borrowed from anime for like the past 20 years before I took that exam. And I was like, holy shit, when is this ever going to be useful? Cells at Work was good though. I did like Cells at Work. I liked Cells at Work Black more, but that's because I'm depressing. Deciding to watch this after my 12-hour ED shift was a choice. Well, thank you for being here with us. All right. 34-year-old man presents with fatigue, shortness of breath, and jaundice. Dude, why do all of these people present with jaundice? Okay, so fatigue, shortness of breath, and jaundice. Do docs secretly celebrate when they find out they made a difficult diagnosis correctly? Okay, Ryoma XS asks the question, do docs secretly celebrate when they find out they made a difficult diagnosis correctly? So, intern year saiken is a February intern, and you know, February interns are kind of memed around because it's like, oh, you feel like you know enough to run the hospital and you think you're hot shit and all this stuff. But I had a very tough patient. Not like he was tough to get better, but just because like the diagnosis was a mystery. But he was like a young guy, super built, like bodybuilder type, coming in with the flu. Recently had the flu and coming in like pretty florid rhabdo. Rhabdomyolysis is when your muscles start breaking down for whatever reason, and because they're breaking down, you're peeing out a lot of the byproducts of their degradation. So they will have like huge amounts of CK in their system, and it'll be like in the 100,000s, 200,000s, and they will basically just be peeing straight blood for like 2 or 3 days. But this guy was having like full body cramps and everything after getting over the flu a few days ago, and basically, long story short, I ended up diagnosing this guy with McArdle syndrome, which is a complete ass pull from first year med school. And it is a glycogen storage disorder. I think it's a type 5 glycogen storage disorder. And it is literally something that you never, ever, ever, ever study, except if you're a first year in med school in genetics and making flashcards getting ready for step 1. But basically, patients with McArdle syndrome aren't able to utilize glycogen storages in their muscles. And this guy was a huge bodybuilder type, and he wasn't overweight or anything, but he was just big muscles, big body. And we asked him, like, have you always like eaten a lot, before your workouts? And he's like, yeah, always. Like, I just have a big appetite. Like, I have a big physique. Like, I count my calories. Like, I need to eat a lot every day. So we like end up getting permission from him to like do the muscle biopsy and send it out to, one of the fancy labs in the city. And we end up like doing the stain, and it ends up showing like the chemical that's like a marker for McArdle disease. And I end up writing a case report on it, just because it was just, a very rare diagnosis that we made from a very innocuous presentation. I think a lot of people would just assume like, oh, he's a big bodybuilder type, like he probably just didn't drink enough water and he went into rhabdo. But going through his history a little bit more, seeing a previous presentation with the same thing, it seemed that every time he got sick or with an upper respiratory tract infection, like he had the flu or he had something else prior to being hospitalized with rhabdo, he wasn't eating, right? Because if he wasn't eating, he wasn't getting enough glucose in his system. And because his muscles weren't able to utilize glycogen, which is a storage form, that his muscles would start breaking down when he didn't have all of that free sugar able in his body. So every time he came into the hospital, it was just after he was working out, after he was getting over like a illness where he wasn't eating as much. So when he was working out, his muscles weren't able to rely on anything and they started breaking down. So that was like a really cool diagnosis where, you know, I actually like had a house moment. And that was like, it's probably like the only one that I still talk about to this day, because that was like my very full, like very, very complete ass pull from something that you'd never think would ever be relevant. Like of all the like sphingosines, right? Newman Pick, Fabry, Gaucher, like unless you're a peds, like you're probably not going to encounter any of these in your clinical practice. But it was just like, yeah, it was like a young guy, like late 20s, early 30s, looked super healthy. You would just assume that he got rhabdo because he overworked himself. But in reality, we did the muscle biopsy and he actually had a genetic disease going on. And we were basically able to treat that and just be like, hey, I think I called into the kitchen for his diet order in the hospital. I was like, can you send him like a double portion for each meal? And then the kitchen was like, I can do like double protein. Like, I can't, like, do you just want me to give him 2 trays? And I was like, yes, I just want you to give him 2 trays. And while we flushed out, you know, his kidneys and helped him with the rhabdo, he just had 2 extra trays, you know, a day of food, and he was totally fine. So that was really cool. Yeah. That was a very long story. How many are we at so far? Are we at 3? Are we at 4? I'm gonna say 4 for 4. 4 for 4. Wendy's 4 for 4. Okay. 34-year-old man presents with fatigue, shortness of breath, and jaundice. All right, and then I remember reading this, and I was just like, what the heck is jaundice doing here with shortness of breath? You should play that new Dr. Robot. Guys, I'm 31. I'm not going to be a grown-ass man playing Roblox. Like, so many of my friends have asked it. Like, I played a DTI like once or twice, and then I think like after that I was just like, guys, like I can't be on this. Like that's just fucking weird. Yeah, Sweaty's right fucking here. Do not put me on Roblox. I have an anime recommendation, Amiku MD. Amiku's pretty good. I remember when it first came out, I did like little breakdowns of each episode. Amiku kind of suffers from the same problem that House does. I think they just pull very elementary associations. So, you know, the information isn't all revealed for you, but it's like at the end of the episode, they'll make one discovery that makes the entire thing make sense. It's kind of like Doctordle in that way. Put this man on Roblox. You'll play DTI with me though, right? In 2026? In 2026? I'm trying to play Doctordle right now. Give me something that links fatigue, shortness of breath, and jaundice. I'm just gonna say hepatopulmonary syndrome. That's a good one. They don't have hepatopulmonary syndrome. Man. Congestive hepatopathy, maybe? All right, so let's say congestive heart failure causing congestive hepatopathy, reversal of flow. He's having right-sided heart failure leading to the shortness of breath, and congestive hepatopathy leading to the jaundice. Okay, it wasn't that. Do you use Anki often? No, because I'm an attending. I used Anki pretty religiously my M3 year for step 2. I tried to dig up some of my old Anki cards my intern year for step 3, did not end up doing any of it. Somebody asked me if I was going to use Anki to prepare for ABIM, and I said absolutely fucking not. So yeah, I was definitely an Anki truther back in med school, but not since then. CHF in a 34-year-olds? I mean, it's possible. I've seen younger patients than that with CHF. What's Anki? Anki is a flashcard app. It is basically like a it's a flashcard app, and it does something called spaced repetition, which is basically like the best way to learn things. I think it was originally invented, you know, to study kanji for Japanese study, but I guess med students kind of just like found out that it was such a good way to memorize a bunch of information, and they ended up co-opting it, and now there's like a whole culture of med students who like swear by Anki and use, you know, these pre-made decks that you can get online to study everything in med school now. So yeah. Hernia? Joking. Do you prefer Anki over Quizlet? Yeah. I mean, Anki is very good at what it does. It's just the problem is for me, I think I'm just like, I'm not wired to learn by Anki anymore. I think the strength of Anki is if you do it for like 300 days in a row, you understand everything. And it's just like I'm not able to like hyper fixate on that as much as I was like when I was back in school, right? Like if I'm working, I don't have time every day to do like 50 Anki cards, right? So it's going to pile up and like it's going to, you know, end up being too much. And that's a problem. That was the problem I had for step 3, because, you know, step 3 you take during your intern year in residency, you're still working, right? So it's hard to balance that with, you know, everything else. Sounds like infection. Let's see. Ooh, wait, Cut 555 says alpha 1 antitrypsin deficiency. So A1AT actually does explain, you know, the wheezing and the hepatomegaly, because it's the elastase damage, right? You would differentiate it from COPD based on if the like atelectasis is like pan-acinar versus lobar or something. I don't remember. Actually, you know, A1AT kind of fits because it's lung and liver. A1AT alpha 1 antitrypsin deficiency. Is this another one where it's like I get it right in 2 and it I get it right in 2 and it's a little sus? Here we go. Yeah, the pan-acinar ones. There we go. Okay. Saiken, how do you have time for this, bro? Because I'm an attending now. I'm an attending in an administrative fellowship, and my MBA is on break for the summer. So, okay, so I'm a hospitalist. I work 7 on, 7 off, right? So 7 days a week, I work, you know, 11 to 11, 11 a.m. to 11 p.m., 7 days in a row. And then I sign out for a week. And during that week off is usually when I do my shit. So that's why I'm streaming today, because tomorrow I go back on service. So I worked some extra shifts. I worked through the holidays just so I can get some extra money, because I do like money. The best part about being an attending is that you get paid for your efforts now. So I got an extra holiday pay. I got a bumped up rate to cover the hospital during the 4th of July weekend. So that was nice. I don't think Anki is a good enough study system. Mind maps are better. I agree. Anki, I don't think Anki should be used by itself, but if you're using Anki to synthesize information from things like UWorlds, Sketchy Micro, Sketchy Farm, like Boards and Beyond, or, you know, Online Meta or whatever, like, I think it's a very powerful tool. But yeah. Causes emphysema in 30-year-olds with no history. Yeah, so I was here, mild wheezing on lung auscultation. Then you're starting to look at obstructive lung disease. But why would you have obstructive lung disease with hepatomegaly? Poor reversibility with bronchodilators means that it's not asthma, and you're thinking more of a COPD. And if you're thinking COPD with liver, then that's probably going to be A1AT deficiency. So I think definitely doable at 3. 2 is excellent. 3 doable. 4 doesn't really tell you anything, but 5 showing pan-acinar emphysema predominantly affecting the lower lobes. I mean, that's literally what I was talking about, like the lobar versus pan-acinar involvement. So definitely you should be getting it in 5, because it's screaming at you at that point. Darn wasn't lupus. Do you think one of these will eventually be lupus? We still haven't gotten there. Onigiri here. I didn't think I'd catch a stream. I found you from YouTube. Thank you. Your little hamster with a clipboard is so cute. That is drawn by my friend Hampone. Ham is awesome. I love Ham. Ham dance is like my most used Discord emote, period. Ah, fuck. Okay. So this is also where I remind everybody that I'm an internal medicine hospitalist. All right. There is going to be a lot of times where I am probably going to run into a peds or an OB-GYN question on Doctordle, and we will just have to deal with it. I don't know, man. We might end the stream here. Straight out the gate, autism, ADHD, poor school performance. I mean, 9-year-olds, poor school performance. I mean, it could be ADHD, right? Because they're just like they're too active, and oh my god. Okay, IQ testing results are within normal ranges, and he forgets to turn in his assignments. I think I could have gotten this at 3. I don't know. Poor school performance is actually like you're probably thinking like ADHD, right? Because it's not like it's probably not an intellectual disability problem. It's more just like they can't focus kind of problem. Common things are common. Yeah. Lupus is a god that exists and doesn't exist. Crystal Blue Knight asks, what is lupus? Systemic lupus erythematosus is a disease where you make antibodies against your own cells and your body basically attacks itself. If you want to know more, you should watch my lupus presentation on Iron Mouse's community presentation stream from like a year and a half or 2 years ago or something. But I did like a full presentation on lupus for that for some reason. Yeah, so poor school performance. Actually, I think I remember from like my board prep last year, poor school performance. Yes, this guy's 9 years old, but I think there's like another one for like 3-year-olds or 4-year-olds. If they present with these similar symptoms, like they forget to turn in their assignments or like they can't wait or like talk out of turn, actually, sometimes it's just because they're too young. You know, like in America, like our school year is like September to June, right? And which means that kids born in the summer usually get bumped to the next grade. But sometimes, you know, if you have a kid in kindergarten, right, who's 4 years old or 5 years old and like they can't follow directions properly, or like they're having trouble learning letters, sometimes it's basically just because they're like younger than they should be for school, right? So it's like you're treating a kid born in July like the same as a kid born in September the last year, right? And that's almost like a whole year of development difference. So it's sometimes really just the age difference when you are that young that like makes it harder to learn in like a classroom environment. How do 3-year-olds even have assignments? Well, you know what I mean. It's like if it's preschool or kindergarten and like the teacher says like draw a square or like a green square or something, right? And the kid like doesn't draw and he just like wants to play with his toys or something. It's because they're like too young to follow directions or something. So I think that was in my, it wasn't on my boards. It was on my step 3 because it was a PEDS question. Yeah. Is that why some kids are held another year before kindergarten? I think so, honestly. It's like and more often than not, it's the ones that are born in like July or August or in the summer months, because it's just like they're just younger, right? That's almost like a year younger. So it's just inappropriate for them, you know, to be in that grade. But just because of the way that we divide the school year, that some kids get shuffled into this grade and some kids get shoved into that grade. I was born in July and I was one of the youngest in my grade going through school. Yeah, so I mean, if you were born in July and you had problems like following directions in like preschool or kindergarten compared to like another kid who was born a year prior in September, I mean, it's just because that kid just like mogged you by like 10 months, right? Like that's not your fault. Like you're just not, you know, as developed as they are. All right. Are we 5 for 5? 5 for 5? I think so. We're doing pretty good. We're doing pretty good. All right, 52-year-old woman presents with persistent night sweats over the past several weeks. Okay, so we're thinking B symptoms, cancers, night sweats. I don't know, lymphomas, lymphoma. Probably not primary testicular lymphoma in a 52-year-old woman. We do like Hodgkin lymphoma, maybe. No. She smoked cigarettes since the age of 18 and reports having a chronic cough for the past year. So I'm gonna say small cell lung cancer. I mean, persistent night sweats is such a non-specific B symptom, like fevers, night sweats, weight loss, all these things. Mucus producing and occasionally streaked with blood. I'm not sure if that... I don't know if that gives us enough information. I think Doc Holiday says TB. It's really cancer versus infection. I mean, honestly, night sweats and cough streaked with blood, I am kind of thinking more like TB, actually. Let's just say TB. Tuberculosis. Oh, it was TB. Okay, nice. All right, we're going through this. We're going through this. All right. She has not seen a doctor in several years. She recently emigrated from Mexico along with a group of laborers to work in the United States. A chest X-ray reveals cavitary lesions in the upper lobes of the lungs. So yeah, once cavitary lesions in the upper lobes of the lungs is not entirely pathognomonic for TB, but TB cavitates, which means it makes its own little pockets, and it goes to the upper lobes of the lungs because TB is a aerophile. It likes oxygen, so it wants to stay in those highly oxygenated zones in the lungs. Sputum staining's positive for acid-fast bacilli because TB, like the bacteria, stains positive on that specific, what is it, like PAS test or whatever. Yeah. Bloody expectoration and chronic cough. Cigs are a red herring. Yeah, I don't think cigarettes, I mean, cigarettes obviously did not help the thing, but I think cough occasionally streaked with blood after it wasn't small cell lung cancer. I think TB is totally a valid guess after that. What else could it be? We had someone positive for mycobacterium and lesions on CXR, came back negative on quantiferon. Oh, interesting. I mean, like, their lesions on chest x-ray, the cavitary lesions don't necessarily have to be TB, right? I mean, I think what's it called? Fusobacteria pneumonia also creates cavitating lung lesions too. I don't know why they would test positive for mycobacterium though, because quantiferon is pretty specific for TB. So unless they did mycobacterium testing with like PCR or something, and maybe they had something come from there. There are other granulomatous diseases. True. So I mean, but why would they test positive for mycobacteria? Also, what would you test positive for mycobacteria on? Lab stain? Huh. But then you would expect the quantiferon gold to be positive though. Huh. There's MAC too. Yeah. I guess if you had MAC, that would also explain it, but also, you know, they would look like a MAC patient and you would think about MAC, right? Like 52-year-old woman with night sweats compared to like 32-year-old man with like long-standing HIV, went untreated for like 5 years, you know, like the pictures would be very much different. That's gonna bother me. Dude, where's Adam Ellick? Where's our ID doctor? Latent? It could just be a bajillion things. Hey saiken, is there a vitamin I can take to lower my body temperature? It's like off the top of my head. I don't know. Is there a vitamin that lowers body temperature? Probably not. I mean, I would talk to your doctor about that. You know, if you're having things like, you know, like hot flashes, or, you know, high basal temperature can not only be a hormone issue, but maybe like a thyroid issue too, or like a thyroid hormone issue too. Like that's I wouldn't say it's just something so simple as like taking a vitamin to lower your body temperature. I mean, there are some very real medical diagnoses that can lead to high basal body temperature. So I would definitely recommend talking to your primary and, you know, try to get some of that done. Aren't we also ID doctors too? We're ID doctors until we don't have permission to order the ID doctor medicines. Is that even possible to lower your temperature? Yeah, that's what I'm saying, right? Like, temperature set point problems are either like a hypothalamus problem or like a hormone problem, like adjusting the hypothalamus for you, right? So it's just, it could be anything. Evaporative cooling is going to be the best one. What do you mean you don't like throwing meropenem around like candy? I'm allowed to order 1 dose of meropenem, and then I have to sign a contract on Epic being like, I promise daddy I will consult the all-knowing ID doctor. And then the pharmacy will be like, okay, he has permission, he's in. I just wanna order colistin, man. I wanna order Avacaz on my own. I promise daddy is wild. Dude, some of these antibiotic stewardship committees like jump on your ass after like 2 days of antibiotics. Saiken, what's your favorite drug name to say? Well, we found out like the other stream that I pronounced tacrolimus wrong. That's why we just say Prograph. I like Eltrombopag because it sounds like a Pokemon. I honestly forget what it does. Eltrombopag. Eltrombopag, sold under the name Promacta in the US, is an oral medication that stimulates the bone marrow to produce more blood cells. Oh, okay, cool. Well, I like saying Eltrombopag because it sounds like an elephant. It sounds like if you showed a picture of Donphan and you were like, yo, this Pokemon's called Eltrombopag, people would have been like, oh yeah, That makes sense. That does sound like a Pokemon. Yeah, exactly. Pronouncing bupropion in Arabic is a tongue twister. What is it? What is the longest drug name you've had to say? Drug names aren't usually that long, and unless they are long, it's because they're like monoclonal, or because they're like antibody medicines, and like those bupropion. You can't forget the bupropion. I would say like they're not long, it's just like the naming convention of like antibodies, so like monoclonal antibodies. So like Skyrizi is probably my favorite one, because like Skyrizi's like generic name is like Rizumkizumab Riza or something. It's so stupid, but it's just so much fun to say. Rizumkizumab Riza. It's like RZAA, so I just pronounce it Riza. Hi, you're on my smart TV right now. Hello, smart TV. Definitely feels like it would be ground type supporting mineral content. Ground type in the mineral egg group. I saw a video called "Is it Pokemon or a Medication?" Dude, I see so many videos that are just like trying to test like med students or something. Like, oh, is this a Pokemon or a medicine? But I feel like by the time you finish med school and you were like, you know, like as a kid, like addicted to video games, I feel like you already know all of the medicines and you know all of the Pokemon. So like the game just like doesn't become fun anymore for somebody like me, because it's just like I already know what the answer is, not because it's like difficult, but it's just because I already have both bodies of knowledge. All right. I think we're 5 for 5 or 6 for 6. I don't remember. 55-year-old man presents with chest pain, fever, and difficulty swallowing since his esophageal surgery 4 days ago. Ooh, bad. Okay, so he had an esophageal surgery, and like now he's got an infection. So esophageal surgery, I'm not sure if it was like a Nissen or something, but I would say like esophageal perforation, right? Red flag for perf, yeah. Borhave syndrome, definitely got to think about this when you have like chronic alcoholics or people who vomit a lot. That can blow up the esophageal lining and start leaking out into the mediastinum. It wasn't esophageal perforation though. On exam, he appears ill, tachycardic, and tachypnic, and diffuse anterior chest tenderness. On exam, he appears ill, is tachycardic and tachypnic, and has diffuse anterior chest tenderness. Is this just mediastinitis? Oh my god, it is. All right, I would have gotten that in one. I mean, like, yeah. So chest pain, fever, and difficulty swallowing. You're worried about an esophageal pathology causing like a rupture of that system. Yeah, like rupture, blow up, right? If you vomit enough or have enough increased pressure in that system, you can really tear the esophageal lining in half. And when that happens, all those contents are going to start leaking out into your mediastinum, which is that chest wall space, and you're going to have infective contents spill out there as well. So maybe he had some injury from his surgery, or he had some, you know, weakness from that surgery, and then all of a sudden things started spilling out, and now he's got a full-on infection in the mediastinum. Yeah, it's an infection. I just don't know what kind of infection it is. It's probably from his like oral bacteria and his oral contents that are spilling out into the mediastinum space, but I think mediastinitis is just good enough for a diagnosis here. I don't think you really need to say anything else. Exploded esophagus. Yeah, that's basically what it is, basically. All right, so Saiken, I'm seeing a new pain management doctor at a new hospital. What documents would be helpful to them to have from me? So your most recent prescription and like your most recent like fill out and stuff. They obviously, you know, if it's the same state, they will have like a full state database to look up your full name and everything, and they'll be able to, you know, print it out and like review the medications that you've been prescribed, the controlled medications that you've been prescribed, and which pharmacies you've picked them out from and which physician prescribed them to you. But it's just nice, at least for the most recent one, that you can show that like, hey, I'm taking these medications, I'm taking them responsibly, I'm getting them filled out at regular intervals. It's just showing the physician that you like understand that, you know, you're not like diverting these onto the street and like selling them and stuff. But yeah. Let's see. 55-year-old man presents with left lower quadrant abdominal pain, fever, and nausea. So left lower quadrant's pretty interesting. There's not usually that much going on there, right? Like right upper, you're thinking liver, gallbladder. Left upper, you're thinking stomach. Epigastric, maybe you're thinking pancreas. Right lower, you're thinking appendix. Left lower is really just your sigmoid colon, which is the part that's connecting your descending colon to your anus. So it's sigmoid because it's like S-shaped and it kind of curves around from the left side of your abdomen down towards your rectum. Popular spot for diverticulitis. So diverticulosis is a common thing that happens in a lot of older adults. Imagine your colon is like a balloon inside of a net. And when you blow up that balloon, you have these little outpouchings that are going through the net. That's essentially what, straining is against like your mesenteric plexus, like all the muscles and the nerves around that area in the colon. So over 50 years of using your colon and straining and having bowel movements, you can develop these little outpouchings. And when these outpouchings get, like food, or like peanuts is a really bad one, blocking those little outpouchings, then you end up, or not peanuts, sorry, popcorns. When you get something like food or like popcorn blocking those little outpouchings, they can get infected and lead to diverticulitis, which kind of leads to like this crampy abdominal pain with this infection. You're not completely pooping out blood, but usually what ends up happening is that you get GI to end up doing an emergent scope and they're just like, oh, it's just diverticulitis. And you're like, oh, I hope it's diverticulitis because this is a pretty good presentation for it. Yeah. So there's a very wide differential for left lower quadrant pain, but diverticulitis is actually a pretty common reason for why people come in here. Popcorn is like fingernails. Yeah. I'm a new fan, so I'm wondering if you've done a Q&A or do you prefer to keep your privacy? I don't really care too much. I mean, privacy obviously is just like, I'm not going to share with you guys like my full name or like my state of practice or like my hospital. But I mean, I'm an internal medicine hospitalist. I finished residency in 2025. I just finished up my first year of clinical practice. I'm currently in an admin fellowship. I'm doing an MBA while also doing administrative work at my hospital too, and I'm on that like physician leadership executive pathway. So that's me. That's who I am. Yeah. So like similar episodes in the past, diverticulitis, diverticulosis, pretty common, chronic constipation. Physical exams revealed tenderness in the left lower quadrant with guarding, but no rebound tenderness. So I mean, it's got like diffuse kind of pain, but it's really on the left lower quadrant where you're feeling tender around there, but without any rebound tenderness. I mean, it's not like something is immediately dying, right? Labs revealing leukocytosis and a digital rectal exam is unremarkable. Labs revealing leukocytosis says that he's got a white blood cell count that's elevated, probably because they're fighting off the infection and the inflammation going on. DRE is unremarkable, probably because, I mean, the problem is in his sigmoid colon, right? You're not going to have diverticulosis in your rectum or your anus, so doing a DRE is not going to be very diagnostic in this case. CT shows thickening of the sigmoid colon with surrounding fat stranding. Yeah, so there is inflammation going on there. No evidence of abscess formation or perforation, so you're not worried about it, blowing open, causing a connection from the gut and the rest of the pelvic cavity. You're not worried about an abscess or like a severe infection like that. And like I said, you manage this pretty conservatively just with antibiotics and fluids. So he's managed with oral antibiotics and a clear liquid diet, and he gets better. There's nothing going on in the left lower quadrant. Yeah, basically. What do you think is the rarest illness you've diagnosed? I guess like maybe 45 minutes into this VOD, you can go scrub and look for the story where I talked about diagnosing McArdle syndrome. That was pretty cool. I imagine they don't put rare conditions in Doctordle. I wonder what mine would say, and then I think about it, it'd be pretty hard. Ooh. Watch this next one be a rare one. 70-year-old woman presents with itchy blisters on her arms, leg, and abdomen. Okay, so blisters. Blisters are pretty specific. So, ooh. What is the scariest disease for you? I am terrified of amniotic fluid embolism. It's kind of like fat embolism syndrome, but like during childbirth. So of course everything is very chaotic, And on top of that, you have amniotic fluid entering the bloodstream, you know, causing a clot. Really just supportive care is your only option, and you just kind of got to pray that it resolves itself. It is a very terrifying thing to happen. Esophageal varices, hidradenitis, shingles. So it pretty specifically says blisters though, right? I mean, it's not like itchy lesions. Like blisters, like there are only 2 blistering diseases, right? Like you're worried about bullous pemphigoid or pemphigus vulgaris, right? Like again, think about this from like a med student level, right? Like it's either PV or BP. And you would basically differentiate those based on the Nikolsky's kind, which is you scrape it away with your fingers, and if it scrapes away, it's one of them, and if the other doesn't scrape away, it's the other one. One of them is like a basement membrane problem, the other one is like a gap junction problem. Dude, I'm not a dermatologist, I don't remember. Let's just say pemphigus vulgaris. Fuck me. All right, it's the other one. She reports that the blisters have been present for several days and are tense and not easily ruptured, so it's bullous pemphigoid. If it's not bullous pemphigoid, I'm gonna end the stream. I don't care. Okay. Oh my god. All right. Bubonic plague. Whoa. Saiken, how easy, if I use this word very lightly in the context of medicine, would you say med school is for someone who's worked in the medicinal field, for example, as a primary care tech, nurse, etc.? I don't think med school will necessarily be any easier for you, but obviously residency will. I talked about this in my video between the difference of between doctors and nurses, but like when you actually learn everything in med school, you have zero ability like to like understand where you fit in like the hospital and like how a hospital works and functions, right? But when you're in residency, nobody's ever taught you that before, and you're like tripping over yourself for like the first couple of months trying to figure that out. Whereas people, like I've had co-residents that had previous experience in healthcare as like patient care techs and stuff, and like they like hit the ground running because they know how a hospital functions. The problem with med school is that it's very insulated because it's really just like an extension of college. Like you're just in the classroom learning about all of this theory and taking exams and everything, right? Like you don't actually put any of it into practice until residency. So you have no idea how like anything works at all. Like as a patient care tech or as a nurse, like probably you're not going to know enough for like the med school level to like do these things. But when you get to the residency level and you're like putting things into motion and like actually applying what you've learned and taking care of patients, then that experience is actually going to help you. Have Lev do Doctordle? Dude, I've asked. Lev is embarrassed to do Doctordle. I mean, because she's a psychiatrist, right? Like, Doctordle is very step 1, step 2 based. Like, it's very general medicine based. I would feel bad for any, like, specialist that has to play Doctordle because it's just, like, I don't think they were, like, they haven't thought of any of this since, like, med school, right? Like, can you imagine, like, an anesthesiologist playing Doctordle or, like, a surgeon playing Doctordle? Like, when is the last time they've probably thought of diverticulitis or mediastinitis or whatever? Like, that's not their problem. So Nikolsky sign negative because it's tense bullae that don't rupture. So that's gonna be BP. And if they do rupture and the skin does slough off when you rub it, then the Nikolsky sign is positive, and that's going to be pemphigus vulgaris. Yeah, so this one is a basement membrane problem, and then which means that the other one is a gap junction problem. Who is Lev? Lev Velikor is a fellow Dr. VTuber. She is a PG. No, she just graduated. She is a newly graduated psychiatry doctor. I guess taking her boards pretty soon. But yeah, she is also in the club of Dr. VTubers. How long have you been a doctor for? I graduated med school in 2022. I did, 3 years of internal medicine residency, and I just finished my first year of clinical practice as a hospitalist. So I've been a doctor for 4 years. I've been practicing independently for 1 year. Ophthalmologist playing Doctordle. What the fuck is a lung? All right, 8 for 8, 7 for 7. We're doing pretty good. We haven't ended the stream yet. All right. 34-year-old woman presents with fatigue, pallor, and exertional dyspnea over the past several months. I mean, at the risk of being stereotypical, it's anemia. IRC pemphigus is desmosomes, not gap junctions. Honestly, you could say whatever and I would believe it. Are gap junctions different from connexins? Are connexins different from desmosomes? I don't know. These are just like random histology, dermatology buzzwords in my brain. But yeah, probably. I knew one of them was basement membrane and the other one's something else. 34-year-old woman probably has iron deficiency anemia. Am I sexist? No, I'm not. All right. So I was the pallor that made me think of anemia, right? So fatigue and exertional dyspnea, it could be a lot of things. You're thinking cardiovascular, you're thinking lungs, you're thinking like for a young woman, things like pulmonary arterial hypertension or whatever. But pallor, like having paler skin, right? Probably because you're anemic, probably because you don't have enough hemoglobin going around your system. That's probably why. Heavy menstrual bleeding and occasional pica. I mean, pica from the iron deficiency means you start eating things that have no nutritional value because your body is so starved for nutritional value in iron. A lot of times you'll see people like chewing on ice and stuff. Conjunctival pallor, spoon-shaped nails, all these things happen. Microcytic hypochromic anemia, so small pale red blood cells. Low ferritin because their iron stores are low, and elevated TIBC because when your stores are low, your capacity to bind iron is high. Anisocytosis and poikilocytosis. Anisocytosis is just saying that you have red blood cells of all different shapes and sizes, and some of them are tiny and spiky because obviously red blood cells aren't being produced properly here because you lack iron. So yeah, we give them iron and they got better. Whoa, hang on, a lot of things here happened. There are a bunch of other Dr. VTubers. Yes, I have a post about all of them. Yeah, so there's me, internal medicine. There's JF, who's internal medicine. Lev is psychiatry. Shiori Pon is in the Philippines. She's a general surgeon. Ruki Yahya is in Indonesia. I think he's family medicine or internal medicine. I don't remember. Bunch of residents out there: emergency medicine, internal medicine, ortho. There's like an orthopedic surgery resident in the Philippines also. I think his name's like Ryan or something. Family medicine resident. Another family medicine resident. So yeah, there's about like 8 or 9 of us actually. Yeah. Am I sexist? No, I'm not. Is it sexist to say women or men have certain medical issues? It's racist to say, if it's sexist to say women or men have certain medical issues, it's racist to say that certain races are more prone to certain conditions. Okay, well, I mean, there are, there's like X-linked conditions that are definitely, really only seen in men. There are, mitochondrial inherited conditions that are really only definitely seen in women. There are, many doctors who believe that certain races are more prone to certain conditions. I mean, so, not spoiler, I think I've said this before, but like I did residency in the South, right? Like in the deep South. Like I was like an hour and a half away from like the next like state capital, right? So I mean, it's there are lots of older white doctors that still practice, having learned the things that they learned when they were in med school in the 70s or 80s, and will have you believe like, oh, like black patients just have lower white blood cell counts at baseline, or they have thicker skin in general, or like feel temperature changes differently. And it's just like, like you still think that? I think I talked about this on Twitter once, like medical textbooks, like, and especially like when you're talking like for like dermatology, a lot of them are just done on pale skin, right? And it's like recognizing different lesions on darker skin like should be taught as much as the textbook quote unquote examples, right? Because like how many times are you going to treat like a perfect textbook case in reality, right? And for us, like our patient population was like 70%, 80% African American, right? So a lot of these things that you learn in med school, once you actually go out into residency and actually start putting these things into practice, you start to think like, what do they mean like that? Yeah, the higher pain tolerance one, right? Like what's like what the hell does that even mean? Hispanic woman with non-alcoholic fatty liver. Must be evidence-based though. On like a population level, I'm sure they did something like that. But like, you also have to think about, like this is research probably done in the same era as like Tuskegee and stuff, right? So it's like, how much are you really going to trust that? I recently watched a stream you did with Cotton and Porcelain Maid about sex ed, and when you got to the menstrual product part, I was hoping y'all would go over reusable products. Did a level with the Diva Cups. Will you ever have a video or stream segment where you go over reusable menstrual products? I guess I can. I mean, I still have a whole thing where I'm begging for an OB-GYN doctor VTuber to appear so I can stop being like a man mansplaining all of this stuff. But I mean, like menses, like heavy menses, PCOS, endometriosis, adenomyosis. I mean, there's like a whole like bunch of different things that I can talk about, like that I barely even scratched the surface with all of my female reproductive health videos. So yeah, I will leave it on there. I mean, I think menstrual cups are super important. A lot of people don't know how they work or the fact that they exist, period. So definitely something that I will keep in mind. Higher pain tolerance one was purely malicious. Yeah, exactly. Like, so how did you figure that out, right? Like, what were you guys doing? Hey, Stinky, hey. All right, 10 for 10? Or 9 for 9? 9 for 9. 60-year-old woman presents with abnormal uterine bleeding. Okay, this could literally be anything. All right, we were just talking about it, so let's just say endo. Abnormal uterine bleeding means a lot of things. It can mean like bleeding outside of your normal cycle. Oh wait, she's 60. Hang on, she's 60. So she should be postmenopausal. So now we're worried more about like a cancer workup, right? So I mean, like endometrial carcinoma. I mean, like an ovarian carcinoma. It's not lupus. Name a uterine cancer. Uterine cancer. Uterine carcinoma. There we go. Endometrial carcinoma. There we go. I would believe it. Ultrasound reveals a solid ovarian mass. Oh my god. All right. What are the solid ovarian tumors? There's like sex cord stromal tumor, but I remember doing that one with Bree, so it can't be sex cord stromal tumor. There's a theca tumor, sex cord thecoma, ovarian theca, lutein cyst, sex cord granulosa cell tumor. Dude, it could be any of these. Granulosa cell. Oh no, I don't know. Oh no. Leiomyoma. I mean, leiomyoma is proliferation of the muscle layers in the uterus. So, I mean, the second question is already saying that she has a solid ovarian mass. So now we're just like running through like all the different ovarian cancers that I know. Ovarian cyst, not necessarily. I mean, she's postmenopausal, so you're worried more about like a cancer causing all of these. Yeah, ovarian cancer, but like which ovarian cancer? Is this where the stream ends? No, I know it's one of these like it's one of these like solid ovarian tumors. I just don't know how to differentiate. Oh wait, okay. I was gonna say I just don't know how to differentiate between all of them. I think histology of the ovary shows lipid-laden stromal cells. This one is probably pathognomonic for sex cord thecoma, right? So a thecoma is a tumor of the thecal cells. The granulosa cell tumor is a tumor of the granulosa cells. This benign sex cord stromal tumor is identified as a cause of the patient's endometrial hyperplasia. Why is that written like a Jeopardy question? So this one's like what is sex cord thecoma? But yeah, I mean, histologically I wouldn't know how to differentiate between a granulosa cell tumor and a sex cord thecoma. So if lipid-laden stromal cells means anything to you, congrats, you're either a pathologist, a second-year med student, or a gigantic nerd. It said, let me help you out. Honestly, who remembers this? I would not remember this at all. All right, 10 for 10, I guess. Stream did not end. We're still going. We're still going strong. I dropped out of hygiene school to become an English teacher. Why am I playing Doctordle? Yes. Don't worry. We're only going until I get one wrong. Saiken, this is important. Somebody doesn't know what lupus is. I've already talked about lupus this stream. So systemic lupus erythematosus is an autoimmune disease where, in just simplest terms, your body is attacking its own cells and it makes antibodies against itself, which means that when your body is attacking its own structural, functional cells, whatever, you end up with a lot of different symptoms that can mimic a lot of different conditions. That's why lupus is such a big meme in house. Lupus is known as the great mimicker because it can affect so many domains, right? Like cardiovascular, connective tissue, renal, psychiatric, neurologic. So depending on where these autoimmune symptoms manifest, you could be, definitely led on a wild goose chase of like a bunch of different systems. So that's why house goes, it's never lupus, because it's too easy to just say, oh, this lupus explains all of this. Can we pin the lupus explanation? I should just make a video on lupus at this point. I already did. Guys, there's a whole ass lecture. I have a whole ass lupus lecture that Iron Mouse watched. It's like 24 minutes or something. All right. 45-year-old man presents with several weeks of subtle clumsiness and occasional trouble finding the right words. Subtle? What does subtle clumsiness even mean? Okay, occasional trouble finding the right words, makes me think of more like a stroke pathology, right? Like we're worried about like vertebrobasilar insufficiency, maybe like TIAs. I don't. Vertebro insufficiency. Do they even have it? No, they don't have it. Maybe like carotid stenosis. Oh, they don't have carotid stenosis? Wow, okay. Let's see. Like hypoplastic basilar artery. That's not one either. Ooh, huh. Like dropping stuff, neuro. Yeah, so that's why I'm on like the stroke pathology thing, but none of what I would diagnose here are like possible answer choices. Frontotemporal dementia is more like personality changes though. Subtle clumsiness is more like an ataxia, so like cerebellar involvement, and then occasional trouble finding the right words is middle cerebral artery involvement, right? So that's Broca's, that's word finding difficulty. Like subtle clumsiness, I'm not really sure if that's ataxia or not. It's just like I don't know. Like, what is subtle clumsiness? I've literally never heard something described as subtle clumsiness before. Don't people just have this happen when they get old? I mean, he's 45. He's not, like, super old. So several weeks, right? It's like, I think it's like, it's some sort of stroke pathology, but it's just, I don't know what subtle clumsiness means. It's like, if I choose to believe subtle clumsiness is ataxia, how are you going to get a middle cerebral artery and a posterior cerebellar artery pathology at the same time? He has an ear infection. I think it's more than that. TBI on the left side that hit Broca's and cerebellum, right? Like, how? Like, how do you, like, that's just very two specific arteries, right? So it's just like, it's middle and posterior. So it's like, that's why I was thinking like vertebrobasilar insufficiency, like circle of Willis, like doesn't make sense. Could it be something in the ears? Well, wasn't there a board question like that where I was like, oh, this isn't actually like a depression problem. It's just like the patient can't hear because she's like, it's like a withdrawing problem. What about a demyelinating pathology? I mean, I guess it could always be multiple sclerosis. Oh no. He denies fever or recent illness, but reports that his symptoms have been slowly worsening. What's the CNS one for the demyelinating, like oligodendrocytes? Oh wait, no, what am I talking about? Don't you love how Doctordle has an option for malingering? We already did malingering, I think. We already did malingering. Glioma? I mean, glioblastoma multiforme, I think, is more of an anterior one. Is it ever something viral like PML? It could be, but I mean, PML, you need to be like a kidney transplant recipient or like pretty advanced HIV with a low CD4 count to be like immunosuppressed. Like, like BK virus, JC virus, like they don't just occur in like normal 45-year-old people. Brain tumor, yeah. I mean, you want to go glioma? We can do glioma or oligodendroglioma. No. Oh my god. On neurologic exam, he has mild right-sided weakness and expressive aphasia. Okay, so expressive aphasia, it means he can't get out the right word. So, I mean, this doesn't really change anything. So he has right-sided weakness and expressive aphasia. So he's got right side symptoms from the left side of the brain and then non-dominant hemisphere affecting Broca's. So, like, what's... Von Hippel-Lindau disease. Jesus. Could be. Try PML. I mean, do you have lesions reaching around? PML. Like lesions reaching around from the cerebrum to the cerebellum. Oh my god. How did you get that? Okay, hang on. Like, 4... His medical history is notable for untreated HIV with a CD4 count of 45. Like, I literally said, like, you would only see this in, like, an HIV patient that is, like, completely immunocompromised. Like, I don't think you can get, like, JC virus or BK virus if you have a CD4 count above 50. So, like, 45 is, like, pretty bad. Have you done the April Fool's Doctordle? Wasn't there one, like, where it was, like, vocal nodules, and they were like, the patient is like a member of the Barden Bellas and sings a lot. Someone said it earlier. Maybe that's still a little sus. Okay, like definitely I could have gotten it at 4, but I feel like getting it at 3 is a little sus. I mean, this probably points you towards it, and then this multiple asymmetric non-enhancing white matter lesions without surrounding edema. I mean, that's just like the definition of PML right there. Honestly, only thought about it because I simply didn't think it could be cancer twice. What traits would you say make a good doctor? Like, what would be the mentalities that individuals who do good in med have? I don't know, just being like... Honestly, it's just being like tenacious, I guess. Like, there's a lot about this job that kind of sucks, but you know, if you really want to do the best thing for your patients, like there's a whole system that you're going to have to fight against. There's like a whole workflow that you got to fight against. But if you really care and you really want your patient to get better, I mean, it's just being able to, you know, constantly go the extra mile and like make sure that they're taken care of, right? You don't just want to shuttle somebody through the system and get lazy and just like do your job like you're clicking through spreadsheets, right? I mean, if the job itself is about treating patients, right? So you should want to treat patients, and you should have that stubbornness to be like, no, like they're my patient, like I'm going to keep treating them XYZ, or, you know, I'm not discharging them from the hospital, I think they're ready, blah blah blah. Saiken is being nice, masochistic is a better answer. Maybe for a surgeon. Hi, Sayu. How many did he get wrong? Chat 0. I've been going for an hour and a half now. We have been going for an hour and a half now, and we still haven't gotten one wrong. So that's why the stream is still on. Subtle clumsiness. Finding the right words doesn't match expressive aphasia exam. Oh wait, I guess not. Yeah, right. Because I was saying like subtle like. Trouble finding the right words is word finding difficulty, which is Broca's, but expressive aphasia is Wernicke's, isn't it? Right? Because it's conductive aphasia that's Broca's. So it's like, man, write your clues. Write your clues better. All right. 45-year-old woman presents with heavy, painful periods. Endometriosis. Random medical fact from neurology. Random medical fact from neurology. Did you know West Nile virus right? Is it? Yeah. WZV encephalitis causes an asymmetric flaccid paralysis, meaning on the one side of the body, so on like, let's say like your right hand side, you have full reflexes and strength. And on your left side of the body, so your left upper arm and your left lower arm, you just have 0 reflexes. That is weird. Like, that's what the heck? One, I've never treated West Nile virus encephalitis, but I just think like the presentation is crazy. Are heavy, painful periods not normal? Unfortunately, no. Uterine fibroids, it could be endo. Chronic pelvic pain and dyspareunia. I mean, we can go leiomyoma, fibroids. Here, physical exam reveals a uniformly enlarged uterus. So leiomyoma is, you know, just an overgrowth of the smooth muscle layer of the uterus. So usually in that case, the uterus has more of like a lumpy appearance because it's more just like little random outpouchings of that smooth muscle growth. CDC just says it's kind of endemic and comes and goes. Wow. That's scary. Does the weakness progress very slowly for PML? I'm not in the medical field. I could see subtle be used for TI could be mistaken for normal clumsiness. Yeah, I don't know. I feel like that question was just weird. Like the clues were worded very weirdly. What are your thoughts on alien hand syndrome? There's a House episode on it. That's all I got. Pelvic inflammatory disease. Yeah, I mean, you would have more like discharge, like PID from like untreated gonorrhea, untreated syphilis. You would have more of like a discharge picture rather than like heavy, painful periods. Adenomyosis is a good one. This is basically endo, but for the myometrium. Actually, yeah, if I said endo, I probably also should have said adeno. Oh, nice. Okay, yeah. So, okay. So, I mean, I think if you said endo, you probably could have said adeno after. So definitely these two, probably doable. Uniformly enlarged is just pointing you away from leiomyoma. Ultrasound shows multiple areas of shadowing, which is basically just going back to the 6th question. So it's endo, but it's growing inside the muscle layer. So that's where you're going to get adenomyosis from. That actually wasn't that bad. Like as a OB-GYN, as far as OB-GYN questions can go, like that, like endo into adeno is not bad. Like I'm actually pretty surprised that I got that one. Mind you, I've never seen House and saiken in the same room. Whoa. House died, remember? Yeah, he went on a motorcycle trip to a state up farm with his dog. A 62-year-old woman is found to have vague abdominal discomfort during a routine checkup. I mean, we already did diverticulitis, but very, very common presentation. IBS you wouldn't really see in a 62-year-old woman, but sure. All right. Physical exam is unremarkable, but adnexal fullness is... Oh my god, it's an OB-GYN question! Adnexal fullness is noted on bimanual exam. All right, so we're back to fucking ovarian cysts again? Seriously? Ovarian corpus luteal cyst, ovarian follicular cyst, ovarian theca lutein cyst. I don't know, man. Oh god. I know. What other masses are there? Lactose intolerance, yeah, exactly. IBS, testicular torsion, obstetrician here. You say V3M. All right, please tell me if you encounter a 62-year-old woman in your clinic with vague abdominal discomfort and have a pretty unremarkable physical exam, but note adnexal fullness on your bimanual, what would you do? What would you guess next? Like, ovarian torsion is a thing? Yes, ovarian torsion is a thing. A lot of people think, you know, just testicular torsion. A lot of people just think like, oh, the ovary is held in place by the broad ligament. It can't, you know, like twist on itself, but it 100% definitely is. Especially with cysts and stuff, the size of it can start pulling at the ovary to twist it around. Ovarian torsion is right there, guys. You would not have vague abdominal discomfort during a routine checkup for ovarian torsion, though. Like, and you wouldn't have adnexal fullness on bimanual exam. Maybe her uterus fell out when she sneezed, like pelvic organ prolapse. But I feel like that would be part of, like, you would see pelvic organ prolapse on physical examination. You would not call that unremarkable. Where was that Yusei person? That Yusei V3M said obstetrician here. Or were they saying they're an obstetrician, or was there anything else there? I like how he takes everything I say seriously. How dare I take what my mods say seriously? Not Eileen says period cramps in a 62-year-old woman. Yeah. Dude, I don't know. Are we worried about cysts? Serous cystadenoma. Fuck it. I don't know. Like, why wouldn't it be? Okay, I feel like you looked that up. How did you get serous cystadenoma before this third one? How did you? Like, I mean, like, okay, I mean, unilocular cystic lesion in the ovary within school walls. Like, like, all right, chat, my eye is on you. Clearly you guys just want me to keep going. Saiken MD is the guy who says, I got no questions right after an exam, then gets a 103. No, dude, I was like a straight, like, A- student. Like, I never got, like, below, like, an A- B+, but, like, I never got an A either. I was just, like, I was thoroughly average the whole time. I don't know. Do we take that one? Fine. Because I feel like the ones where chat ends up, you know, giving me the correct diagnosis, like, I still probably would have gotten it by, like, the third, fourth, or fifth one, so I think it's still valid. I feel like if somebody just says something out of nowhere, then we're gonna be like, all right. All right. You think this is good for recognizing illness scripts for the ABIM? Absolutely not. I mean, we actually do ABIM board review on this channel, because I run through it with a couple other internal medicine doctors, and, like, we actually do, like, redacted board review resource, but we actually do those questions on stream, and that's a much better time than step 1, step 2 buzzword city. But a lot of people like Doctordle, so here we are. 6-year-old girl presents with small flesh-colored bumps on her trunk and arms that have been present for 3 weeks. Not a doctor, but a respiratory therapist. Give him a duonev. Yeah. Yeah, there we go. There we go. Oops, back to peds. I mean, small flesh-colored bumps for 3 weeks. I mean, that's like molluscum contagion, like pox virus, right? Like, that's just like what it is, right? All right, good. All right. I remember something from peds, guys. Yeah, so, I mean, pox virus is a big fat virus. Monkeypox, if you remember, that was a thing. Remember when monkeypox was a thing? They're just really big viruses that live on the skin. They cause, like, inclusion bodies, I think. It's really not. It's not that important. It goes away. Like, yeah, she is advised on hygiene practices to reduce the spread and to monitor for spontaneous resolution. Yeah. Just watch. The one after this will be peds. Please no. How many have we done so far? 12? 6-7-year-old man presents with difficulty urinating and nocturia. Okay, so difficulty urinating and nocturia. First things you're worried about in an older man is BPH, so benign prostatic hyperplasia. The prostate gland is an enlarged gland. Oh, okay, I got it right. The prostate gland is a little walnut-sized gland that, like, sits in between the bladder and, like, the urethra. It kind of controls the open gates, if you will, for the urethra. So one way allows urine to flow through the urethra and out the penis. The other way allows, you know, sperm and seminal fluid and semen to flow out of the penis. Not really flow, but you know what I mean. It enlarges with age, enlarges the testosterone exposure. So BPH is a very common thing that affects older men. And an enlarged prostate starts pressing on your bladder, starts giving you these symptoms where you feel like you need to urinate at night or you don't fully empty. And yeah, so weak stream, sensation of incomplete bladder emptying. That's definitely what I just said. Monogamous with a spouse of 42 years and denies any history of sexually transmitted infections. So prostatitis is definitely another possible thing. Prostatitis usually is associated with STIs. But obviously this guy, there were 2 of them that just said he has no infection. So no dysuria, hematuria, or fever. You're not really thinking about a UTI or prostatitis either. Digital rectal exam. This is what we do rectal exams for. All right. Not only to look for poop, but to actually feel the prostate. And if the prostate is small and normal, or large and boggy, or smooth, non-tender, or like hard and spiky. Like those all mean different things. So, you know, benign enlargement, prostatitis, prostate cancer, etc., etc. All right. 35-year-old man presents with swelling in his legs and occasional headaches. He reports feeling more fatigued over the last few months. Okay, so we've got swelling in his legs and occasional headaches. What does spiky prostate mean? Like kind of like spiculate. Like it's got like pointy bits on it, right? Like it should be like the prostate should be like a small, smooth surface, right? Boggy is like enlarged and soft. Spiky for prostate cancer, it would just mean like irregular and uneven. So yeah. DVT, that's a first worry. Skin. Did you know the difference between pemphigus vulgaris and bullous pemphigoid is the presence of a positive or negative Nikolsky sign? Bullous pemphigoid being a basement membrane problem and pemphigus vulgaris being a desmosome problem. CKD, check for fluid retention. Yeah, but then you're thinking like, what do headaches do here? But I mean, yeah, if it's kidney disease and he's got proteinuria, you're gonna get swelling in the legs, more fatigued over the past few months because, you know, it's fatiguing him. Hello? They don't have CKD? Oh, okay. All right, I guess we're not allowed to say CKD. Lymphedema, I know I have swollen legs from that. Yeah, but then you also got to think about headaches too. Uncontrolled hypertension. Could be. We're saying uncontrolled hypertension led to heart failure, right? So high blood pressure would kind of give you those headaches, and swelling in the legs would be, you know, a heart failure problem. No, wait, I don't have lymphedema. I just know people who do have swollen. Oh, okay. No CKD? No CKD? Burger disease. Whoa. Could it be diabetes adjacent? I mean, diabetic nephropathy. I don't know. It could be like any nephrotic thing. Let's type in nephrotic. So we've got membranous nephropathy, could be. Diabetic glomerular nephropathy, could be. We got Burger. We've got membranous nephropathy. We've got focal segmental glomerulosclerosis, elevated blood pressure, and bilateral lower extremity edema. Well, I mean, yeah, somebody was right with the blood pressure problem, right? Blood pressure can totally cause the headaches, and bilateral lower extremity edema. I don't think Burger disease would cause... Actually, no, it wouldn't. I don't think Burger disease causes hypertension. I mean, it's kidney damage leading to hypertension. FSGS, yeah, I think blood pressure is more of like an FSGS picture. Okay, cool. Yeah. 3+ protein. So he has a history of obesity and long-standing hypertension, but no known diabetes or autoimmune disease. So, I mean, the kidneys are going to be the ones bearing the brunt of that. And he's also on heart for HIV and has a history of heroin use. That is pretty on the nose. I feel like directly on Pathoma, it says that FSGS is associated with IV drug use and HIV. And then the 6th question says kidney biopsy says segmental glomerulosclerosis and hyalinosis with some glomeruli with focal foot process effacement on electron microscopy. So, I mean, yeah, it really says it's focal segmental glomerular sclerosis. Yeah. I mean, it was this one definitely was pointing towards a nephrotic syndrome. So, I mean, if you just went down the list of nephrotic syndromes, you probably could have gotten FSGS. All right, a 55-year-old man presents for a routine exam with no complaints. What the fuck am I supposed to do with this? How is this a diagnosis? What? Chad syndrome. Wait, what the fuck do I do with this? How are you supposed to do this? He's a chill guy. Obesity. Chill guy syndrome. Chill guy syndrome. I mean, maybe it's like something that like you wouldn't like discover, right? Like maybe it's like lung cancer, right? And it's just like you don't Like, what is like adenocarcinoma, right? Like, he has no complaints on his routine exam, but then you like 6 months later, he like shows up for like a scan and gets, you know, found out to have lung cancer. Dude, what the fuck is this? His history includes well-controlled hypertension and he takes lisinopril, so he's fine. Essential hypertension. Actually, I think we already did a Doctordle that said essential hypertension. It was very stupid. It was very stupid, but it was essential hypertension. Bro's diagnosis is no. Dude, what the fuck is this? Locked in syndrome? He's fine. How would you not feel lung cancer? Because lung cancer, I mean, depending on where it is, like, you just, like, you don't know because you don't have any symptoms. Like, lung cancer is very asymptomatic until usually it metastasizes somewhere. And then you would have symptoms of that metastasis that leads you to discover the lung cancer. Diabetes? Sure, dude, I don't, what is this? Oh my God. Physical exam is unremarkable with a heart rate of 60. It's just bradycardia? Why is he at the doctor then? Exactly. No, why is he on Doctordle? First degree AV block. Right? First degree AV block is just asymptomatic bradycardia, right? Like sinus brady, and then you just deal with it. Oh my God, that was so stupid. What the fuck? Why didn't you intro with this? Why did you give 2 lame clues? These weren't even clues. These were just statements. Bro, he just wants to see you. So what I'm hearing is there's no pain receptors in the lungs. I mean, like, if you have a significantly big enough lung cancer that's like impacting, you know, a lobe or individual alveoli and you're feeling short of breath, then like, yeah, it's definitely, you know, symptomatic, and you will probably be able to diagnose that once imaging is ordered. But, you know, like, for example, my dad has lung cancer, and he wasn't diagnosed until after it was already stage 4 because he was totally fine. And he got it discovered when he was found to have jaw metastasis. He had like jaw issues for a while, so we thought it was like TMJ or something, but eventually, like, they did an x-ray of the jaw, and like the x-ray showed bone destruction and then like a little shadow of like a cancer, like a little spiculated growth in his lung, and it was never big enough to like cause any problems, but that's how he ended up discovering like he had lung cancer for, you know, who knows how many years. But I mean, he was just like completely asymptomatic until it metastasized to his bone and like to his jaw. My granny got hit by a bazooka. How would you diagnose? Rest in peace, my granny. She got hit by a bazooka. And you usually don't do screening EKGs for the most part. Yeah, like, why are you here, dude? Why are you in this question in the first place? What is a spiculated growth? Spiculated just means like spiky. That's like the technical term for it. So like it was just like a very small growth, right? So it wasn't like big, like collapsing his lung or like impacting the way he breathed or anything. So it was just like a very small irregular growth growing, but you know, you wouldn't have known that just because he had no symptoms the whole time. He's here for the sheer love of the game. Yeah, he just wants to see me. My dad has a liver carcinoma and is just chilling. Yeah, I mean, usually for many cancers, like unless it's like, you know, GI or something that's very obviously causing symptoms, it's hard to diagnose these because you won't know until they metastasize somewhere else and then cause problems somewhere else. Hoping he's all right, and fascinating how it shows. Yeah, he was on a tyrosine kinase inhibitor for a while, and then he switched over to chemo. He's chilling. He's chilling. Bet Potts in a 72-year-old man. All right. Mecha. Oh my God. Hello. Welcome to the chat. Sorry to hear about the lung cancer. Did you know that Asian women never smokers have a disproportionately higher risk of lung cancer, though? That is interesting because I literally just saw it in our doctor's lounge. It was like a thing telling you to screen like your female Asian non-smokers for lung cancer. That's crazy. I posted a selfie on my Twitter the other day from 4th of July. And I took that in the doctor's lounge. Like literally right behind me in that photo is that screening poster, like about like screening Asian female non-smokers for lung cancer, which is showing to have higher prevalence. That's crazy. Wait, it's literally like it's in the lounge. Let's see. What makes something chemo or not? Chemo is therapy with chemicals. So for him, he was on a tyrosine kinase inhibitor, osimertinib, and that's like a pill that he just had to take every day. Chemotherapy, now he's on chemotherapy. That's like an infusion, more like. And I mean, there's different ways of treating cancer, right? Surgical, radiation, chemo, and chemo is usually a combination of like cytotoxic drugs that are being delivered into the system in like a controlled setting, right? So you go to an infusion center to get this done with like nurses to administer the medication and everything. Adenocarcinoma, isn't that with never smokers? Yeah, I mean, my dad was a never smoker. Or actually, no, he was a smoker, like when, before I was born. I mean, he's Korean, of course he's a smoker. I think he quit after I was born though, but it was like remote history. So like 30 years he hadn't smoked, and then he got adenocarcinoma. The layers on why with the non-smokers though, like beyond secondhand smoke, oh, I don't know. Genetics probably, but the specific poster and you know what the comment was saying was like, yes, like female Asian non-smokers have a higher risk of lung cancer than at baseline just because of like the prevalence. He had an EGFR mutation, yeah. So he had an EGFR mutation. I got my labs done for free, which was nice. So I don't have the EGFR mutation. So I'm not going to get lung cancer, guys. Yay. Or I don't know, maybe I will, but it won't be due to an EGFR mutation. But yeah, he had an EGFR mutation and responded pretty well. I think his oncologist showed me the trial. I think it's called like the Mariposa trial, something like that. But yeah, like these EGFR lung cancers respond pretty well to tyrosine kinase, like orals, which is cool. Question, why does chemotherapy usually involve shaving the patient's head? So chemotherapy, you're trying to kill fast dividing cells, right? Because you're trying to kill cancer cells, right? And fast dividing cells are located in cancers that are growing out of control, and they're also occurring in your hair follicles on your head. So, I mean, usually, like after a course of chemo, the patient's hair is probably going to fall out. So, you know, preemptively shaving it is just what you do, you know, before you deal with, you know, the stress of that from the chemotherapy. Crazy timing with the poster selfie in the chat. Yeah, I know, right? All right. So, brief loss of consciousness while shopping for groceries. I mean, we could just say vasovagal syncope. Wow, they don't have any kinds of syncope? Vasovagal syncope? No? Hello? Orthostatic hypotension after the patient stood up from the bottom shelf to grab wheat bread. All right, that's a good one. Right? He got the Mr. Krabs, he got dizzy, and then he fell over. No, okay. He reports a feeling of lightheadedness before the episode, but no chest pain or palpitations. Lightheadedness, so I'm thinking like blood pressure, blood flow problem. Like, why isn't carotid stenosis a thing? Carotid sinus hypersensitivity. This one's a good one. This one's usually like if they're wearing like a tie or something and then they pass out. Oh shit. Yeah, so carotid sinus hypersensitivity, it's like the blood pressure receptors on, you know, the carotid bodies are too sensitive, right? So any sort of stimulation around them. So yeah, you either find it with like people who wear like really tight ties, or he was turning his head to the side to look for an item on a high shelf. So that position that he put himself in, where he was turning his head to the side, was compressing his carotid sinus, and that's how he ended up passing out. Yeah. During evaluation, gentle pressure applied to the right side of the neck reproduces the symptoms and results in transient bradycardia. Yeah, so this is what you're actually supposed to do to diagnose carotid sinus hypersensitivity in the office. Remember to only do this on one side. Do not try to do this to both carotid bodies at once, because that would be very bad. What's the heart bradycardia version? What do you mean heart bradycardia version? Like sinus pause, like 3rd degree AV block, or like something? I was guessing lupus or anything related to imbalance from his ears. Could have been. We didn't have that many clues. But I feel like I was thinking carotid stenosis, and then I typed in carotid, and then it gave me carotid sinus hypersensitivity. This one, clue 4, is a very good clue to have. This one's going to be the one that actually you know, locks in carotid sinus hypersensitivity for you. Like when you think about the physical maneuver that you do when you turn your head to the left, like you are compressing, you know, that artery ever so slightly. And for somebody with the carotid body hypersensitivity, they're going to suddenly drop their blood pressure. All right. A 28-year-old woman presents with a painless bump on the dorsal side of her wrist. Ganglion cyst? I mean, it just has to be a ganglion cyst, right? Like, what else could this possibly be? Like, this isn't even like a Doctordle question. This is just like, do you know what this is? What would be the treatment for that? For ganglion cyst? For you just smack it. I think like I read a paper where like actually like doing the Bible thump, like smacking the ganglion cyst and surgical resection of ganglion cyst actually have like pretty similar outcomes. Like more often than not, like a ganglion cyst is going to recur, but like apparently that recurrence rate between smacking it with a book and getting a surgical like resection is the same. But yeah, so what I think you meant was like the carotid sinus hypersensitivity. So I think you use like blood pressure raising medicines. So things like midodrine or Florinef. These will basically counteract the drop of blood pressure because basically your carotid sinus, the carotid body, is too sensitive to being compressed in these positional changes that are causing vagal stimulation, and it's dropping your blood pressure immediately, and that's why that guy's feeling lightheaded, and that's why he's falling over. But for this problem, you treat it with blood pressure medicines that raise blood pressure, not lower blood pressure, so that it kind of counteracts that hypersensitivity. But if he's not just going like transiently bradycardic, like if he's actually like his heart stops, then you need to put in a pacemaker. So actually maybe like bradycardia of 60, I think is fine, but like if he drops to like the 30s or something, right? Or just like his heart like sinus pause of like 10 seconds or something, like that's definitely like pacemaker goes in immediately. Like your risk for sudden cardiac death would go way up. My aunt thought she had a ganglion cyst in her hand. It turned out to be an aneurysm. Oh goodness. There's a reason they're called Bible bumps. Yeah. Gotta whack it. Oh my god. Guys, it's been 2 hours. I haven't gotten one wrong yet. I feel like we're gonna go forever. All right. 44-year-old man presents with recurrent upper abdominal pain and diarrhea. You have to do it without suggestions. I mean, like, yeah, even the ones where chat gave me the answer, I still identified like which clue I probably would have gotten it right. Do you want me to just not look at chat anymore? Do you want to just do as many as I can without looking at chat? 44-year-old man presents with recurrent upper abdominal pain and diarrhea. Recurrent upper abdominal pain. That's just this period. I mean, it could be like pancreatic insufficiency, maybe. That could be a good one. IBD? IBD? Yeah. Treated multiple times for peptic ulcer disease, but his symptoms return quickly after standard therapy. It makes like, it keeps making ulcers, tumors. What's it called? Zollinger-Ellison syndrome. There we go. Yeah, so this one is literally just like you have, oh, it's also associated with Men1, but you basically just have like this condition that causes you to make a bunch of ulcers, and like you really just have to give them as many PPIs as possible. You can always ignore chat if you want to stop on a hard question. All right, I'm gonna stop reading chat in the middle of doing a question. I'll try to like one shot these questions, and then we'll discuss and we'll yap. Zollinger-Ellison, yeah. I think YouTube might be behind. YouTube might be behind like maybe like a minute or two if you guys want to refresh. Wow, there's 245 of you. Wait, there's 245 YouTube viewers and 118 Twitch viewers. That's like, it's like 307. Dang, that's cool. Turnout. That's why I'm doing Doctordle, because everybody just wants to watch me play Doctordle. All right. Well, I got Zollinger Ellison without relying on chat. I still remember. I'm an internal medicine doctor. GI is part of my purview. 6'7", 367. That's what I said. 367 CCV. I love how you refuse to play Roblox but make 6'7" jokes. All right, like, fuck you. Fuck you. Complementary system, please. So complement deficiency is usually like when you have, so the complement system is basically like a bio immune system like attack drill, and it basically, like, when it sees foreign things, a number of proteins from like C1 to C9 come together and assemble a drill, and they drill into the bacteria and burst it open. Complement deficiency is a certain type of immune deficiency syndrome where you lose the ability to make the back half of those proteins, like specifically like C5 through C9. And if you can't make that attack drill, then you have trouble clearing out encapsulated organisms that would need to be killed by that complement formed drill. So these people will usually have like recurrent infections. The infections themselves can blow out of proportion really quickly. So even things like simple UTIs, even if left untreated for maybe like a day or two, like definitely could blow up into like full-blown sepsis or something, just because of like the infectious load just existing in them at that point. So yeah, complement deficiency, very, very real. You should play one of those hospital roleplay games on Roblox. Go away, sweaty. All right. 35-year-old man presents to the ED with seizures and headaches that began 2 weeks ago. So he's only had seizures for 2 weeks. That's crazy. So yeah, like a brain tumor can cause seizures, but like 2 weeks ago. So, so you're worried about like maybe like an infectious growth. So I'm worried about like maybe it's another HIV patient, right? Maybe it's like toxoplasmosis. So Toxoplasma gondii can go to the brain, cause these lesions. He has no prior history of seizures or neurological symptoms, and he takes no medications. So again, it's probably just telling you this is like an acute thing that happened 2 weeks ago. This is probably an infection. It's not toxoplasmosis. What else goes to the brain? We already said PML for another one, so I don't think it'd be PML. Didn't I make a post about Taenia solium? Like neurocysticercosis. Oh shit, it is neurocysticercosis. Okay, so neurocysticercosis. I think, what was it? The tweet was like, oh, VTubers always talk about brainworms, but we already know how to treat neurocysticercosis. Because it's, neurocysticercosis is Taenia solium, the pork tapeworm. It's the one that you get from eating undercooked pork. This one can go to the brain and start causing these cystic lesions. And anytime you have something growing in the brain or bleeding in the brain or pushing on the brain or just anything being in that brain space where only there's supposed to be brain and you have something else going on in there, it's going to cause different neurological deficits. And in this case, it's pushing on something and it's causing seizures and headaches too. But again, it only began 2 weeks ago, right? So obviously this wasn't something that he's born with. You probably wouldn't have like a full-blown like meningioma or, you know, a glioblastoma manifest in 2 weeks. So this is probably an infectious source. Taenia solium causing neurocysticercosis, probably because he had, you know, oh, here. He recently immigrated from Central America where he was an agricultural worker. So he probably was exposed to it over there. There's a 4-man co-op called Night Shift Hospital coming out on Steam soon. Yeah, so that's I think somebody else tagged me in it on Twitter, but I definitely want to try playing it with a bunch of like medical and like non-medical friends. Like, I think like JF, Shiori, some other people are down, and then just like, can you just like, imagine playing like a medical simulation with Bree? Like I would shit myself, right? Like, I think Krydia wants to play with me too. Terra wants to play it too. So it's a whole shit show. It looks hella fun, yeah, dude. All right, how many of these have we done? 20? Have we done like 20? Dude, I still haven't gotten one wrong yet. 14? All right, 14. All right. Out of curiosity, is there something that can infect the fluid in the skull? Yeah, so your brain is basically bathed in a solution called cerebrospinal fluid. And you can get infections in this space. So this is what like something like a lumbar puncture is for. We go into the spinal cord and basically like pop the sac and draw the fluid from it to take out for culture. But something like CMV encephalitis, cytomegalovirus encephalitis, it basically just lives in that area and causes inflammation of the brain. So you figure that out by doing an LP and then doing a PCR from that LP fluid. Would you consider the cerebral spinal fluid the cleanest fluid in your body? Yeah, because nothing else should be in there. You should just have like glucose and protein and wet. That's it. Is an infection of the fluid in the skull meningitis? Yeah, so meningitis refers to inflammation of the meningeal layers that cover the brain and the spinal cord. So the dura, the arachnoid, and the pia mater. Inflammation on any of those layers is meningitis. So also can be done by CMV, also Neisseria, also like a bunch of different things. So that's, you know, what the LP is for. But yeah, so infection of that space is meningitis. Infection of the fluid going around and into that space is going to be what you're going to find from the CSF. We learning things today. We learning. Maybe he's paranoid. I mean, there are psych questions in this. I would say like paranoid disorder or like schizophrenia or schizophreniform or schizotypal or schizoaffective, like totally fair game. Lucy the Real One redeemed a hot fire emblem take. Three Houses? I don't want to talk about Three Houses. All right. Three Houses is a terrible game for new Fire Emblem fans, but unfortunately it's the one that they're exposed to because of all the Tumblr discourse surrounding Edelgard. Three Houses' biggest sin in this regard is the free class system, where you can basically make anyone anything, and where anyone can basically wield any weapon with the exception of gauntlets and mounted units and gauntlets and mages, because it really just destroys class identity, and it really destroys unit identity too, because you feel pressured to keep units in their canon classes, but also at the same time, the game encourages you to experiment, but at the same time, the experimentation of that takes away from their own identity as units. It feels bad to play, and it feels even worse to explain to a newcomer who might not even understand what the class tree and promotion system even exists in a normal Fire Emblem game. So giving them free reign on an open field with the Fodlan way of doing things is absolutely insane. Saiken MD, did Edelgard do anything wrong? Yes. Yes. Hey Doc, have you heard of the anime Amiku MD yet? Yeah, I talked about it earlier this stream. I mean, Amiku suffers from the same problem that House does, where it's a mystery up until they give you like a very like obvious like red flag thing in the story. And after that, it's just like a very simple first order association, like on a second year, third year med student level. Amiku does the same thing in its first episode that House does in the Sporothrix episode, right? Like House goes like, did you handle roses? Did you prick yourself with a thorn? And the patient's like, yeah. And he's like, oh, it's Sporothrix. And of course it was sporotrichosis. Like, fucking stupid. Like, you watch the whole episode and play along and not get a diagnosis until the end, just when he reveals that one clue. Amiku does the same thing. Like, as soon as she talks about the tropical fish and the methylene blue poisoning, I mean, like, that's literally what the diagnosis is. So, would you rather get into a Twitter argument with a Three Houses fan or Engage fan? I would rather get into a Twitter argument with an Engage fan because at least I know that they appreciate the series. Gameplay wise, I think Engage is one of my favorites. I mean, Genealogy of the Holy War and Thracia and 776 are my absolute favorites, but Engage is definitely a third place, and gameplay and replayability wise, I think definitely is up there, like in my top 2, just because like Engage just feels good to play. Like, not even just like the smash weapons and the breaking system, but just like the infinite replayability of emblem rings and assigning them, and like all the different combinations that you can do, especially with like the DLC and the DLC classes. Engage rings are what FE4 or FE3 Houses crests wanted to be so fucking badly. Like, they're both like world-changing powers that shape nations and everything, and Engage is literally just like, oh, you just get to like sweep an entire map by yourself, or you get to move 13 spaces or whatever, and then a crest in Three Houses is like 30% chance to recover, you know, 30% of your health when using a combat art. Like, fuck you. What the fuck? Path of Radiance is just like, you know, the best game. You and Sayu would get along. I like the Tellius games. I don't think the Tellius games are perfect. I really appreciate the scale of Radiant Dawn, but I mean, it's not like, it's not a work of art or anything. It's just a good game. It's a solid game. Yeah. But at the same time, some characters have relics not in their class. That's true, but I mean, are you really using Crusher on a net? Like, most people make a net a Gremory. Like, are you still really using Crusher as Gremory a net? Are you still trying to use, like, are you still trying to use... I'm trying to think of another, like, one that doesn't make sense. Whatever. Since you say Three Houses is bad for new players, what would you consider when okay, if you're legitimately serious about getting into Fire Emblem and you don't mind, like, playing with translation patches, FE6 is a wonderful game to start with, because I think it teaches you everything about Fire Emblem. If you don't want to be a super snotty elitist and you just want to get into Fire Emblem, FE7 is a much better starting place. I mean, that was the first Fire Emblem game released in the West. So it introduces the whole series and like introduces very basic mechanics, like the weapon triangle, like the support system, rescuing, like weather conditions, like very like basic stuff, right? I think Path of Radiance is fine. Radiant Dawn obviously doesn't make sense because it's a sequel. Sacred Stones, I think some people get put off by the open worlds map design and they can fall into the trap of like grinding in the Tower of Valny, which just ruins game balance. 11 and 12, I mean 12 wasn't released in the West either. Like Shadow Dragon's not a bad game, but it's not a good game either. Like Shadow Dragon's mid. Shadow Dragon's like mid as fuck. Where do you put Awakening on this list? I mean, Awakening I would say would be in the tier 2. I mean, Awakening also has a open map design with infinite grinding, especially with DLC too, right? So I wouldn't recommend Awakening as like a first one. Oh, weapon weight, which is taken out back and shot in later games. At least they brought back weight and builds in Engage. I appreciate that. I appreciate that. I turned a net into a Wyvern Lord in 3 Hopes. Everybody goes into a Wyvern Lord in 3 Houses and 3 Hopes. All right, I gotta stop looking at chat. All right, 32-year-old man presents with a 2-day history of malaise and agitation. Okay. Malaise and agitation. So he's lethargic. What? Malaise and agitation. So he's just not feeling well. He's feeling crummy and he's agitated. What? I don't know. Meningitis? 32 is pretty old though. Maybe he's like a Navy officer. He lives in crowded bunkers. No. He reports recent symptoms of sweating, rhinorrhea, abdominal cramps, diarrhea, and okay. Well, I mean, they literally just listed all of the symptoms of opioid withdrawal. Oh my god. Physical exam reveals dilated pupils, lacrimation, and piloerection. So that's dilated pupils, tearing, and like hair on the end of the skin is standing up. Heart rate, BP are elevated, temp is elevated, symptoms improve with supportive care, including antiemetics like Zofran and fluids, and he reports recently stopping heroin. So this is why you don't, instantly try to quit opioids cold turkey, because this is, a very real thing that happens to patients. When you're trying to taper off of opioid or, substance use disorders, I mean, we try to get patients into methadone clinics or give them a medication called Suboxone, which is a combined buprenorphine medication, and it's a partial agonist in this case, and it kind of helps patients ease off of having all of these opioids in their system. So they're not going from 100 to 0, they're being gently weaned off of. Why do doctors use such big words for he feels tired and crummy? I don't know. I don't know. My doctor, sir, do you recommend working inside fuel cells to apply toxic chemicals on the walls for several hours in the day? No, I do not recommend that. No. What's the worst withdrawal symptom, and why is it alcohol or benzo withdrawals? I mean, so alcohol withdrawal can kill you, right? So for any patients that are in danger of withdrawing or actively withdrawing in the ER, like, we have to admit them, because alcohol withdrawal, the way that it interacts with your GABA system, it's not just things like, sweating, tremors, like full delirium tremens can lead to things like seizures, coma, death, right? So, I mean, you have to, take care of them like symptomatically with like a benzotaper or with drugs like phenobarbital, so luminol, or chlorpoxidide, right? So alcohol withdrawal definitely can actually kill you. So a lot of other things like withdrawing from amphetamines or withdrawing from heroin can't directly kill you. So it's like, I mean, if they presented to the hospital like this, right, they would probably just be kept in observation in the ER, right? Because they improve with supportive care with, antiemetics and fluids, because they really just need to just be taken care of, right? Probably same thing with amphetamine withdrawal and stuff. But alcohol withdrawal definitely, really needs to be taken seriously. Give us a fact about antiphospholipid syndrome. Antiphospholipid syndrome is associated with the anticardiolipin antibody, which, if you watch the Doctordle video that I did with Bree, is also associated very many times with lupus. Actually, I looked it up after I did that stream, but in a woman with more than 2 recurrent miscarriages, you do need to do the antiphospholipid syndrome workup and check that very specific antibody, because it is a common cause of recurrent miscarriages, because their bodies are basically attacking the fetus. Yeah. So never stop drinking alcohol. That is not the takeaway here. That is not the takeaway here, but that is how it's managed, right? I mean, chronic alcoholics drink alcohol to not withdraw because that saves their lives. This is also why in a lot of older hospitals, so not at my hospital, but not at my hospital, not at the hospital that trained at residency, and not the hospital that I went to med school at, but one of those hospitals during my 3rd year rotation, which is more of a rural hospital, totally, I would not be surprised if they actually allowed you to do this, but they had beer as part of their order set, right? Because if you're trying to treat alcohol withdrawal and you don't have a lot of these medicines to treat alcohol withdrawal conventionally, you can give them more alcohol to stave off these symptoms so that you have time to get that shipment of that medication, because that will inhibit the GABA channel that you're going for, that will, if kept, unchecked, will cause those withdrawal seizures and stuff. So yeah, don't cut cold turkey. That too. I mean, I think it's admirable when patients do, but for patients with a history of withdrawing or going from, 100 to 0, probably don't quit cold turkey, or at least try to check in to a hospital before you quit cold turkey, because, these things are very real. And I mean, it's not like patients are trying to quit cold turkey by themselves, but it's more like, it's like somebody comes into the hospital, septic or in diabetic ketoacidosis or something, right? And they are hospitalized for 3 or 4 days. And also that person happens to be a very heavy drinker, right? Then you have to be worried about withdrawal. So this is why, it's important to get the medical history. And if you can't get it from the patient, talk to the family, call their nearest contact, try to figure out what their habits are. Because, you could be treating someone for DKA, you could be treating someone for a critical illness. And then you also have to worry about withdrawal on top of that all of a sudden. So that becomes a very real thing that happens too. Good afternoon, doc. It's not afternoon here, but good afternoon. Do you choose what kind of beer you get? Probably not. It's probably Coors Light or like PBR or something. They probably buy it from the grocery store and they keep it for like the 1 or 2 patients that they have to treat alcohol withdrawal with beer. But yeah, it's definitely like a legitimate thing. I heard about the fact that you need to give him some alcohol to avoid a horrible withdrawal effect. The side effects scare me just hearing about him, even as a non-drinking Muslim. Yeah, alcohol withdrawal definitely gets overlooked in the hospital a lot. Like I said, it's not really, you're not usually treating it as like somebody who's trying to detox from alcohol cold turkey 100%, like 100 to 0. You're usually encountering it in one of your critically ill patients in the hospital for a couple of days. And then they mention like, oh yeah, actually, doctor, like I drink like 20 beers a day and then I crush a 40 every weekend. And then I'm like, okay, well, it's day 3 of your hospitalization and you have not had a single drop of liquor. And now you're, tremulous and sweating and I need to fix this. So yeah. All right. A bunch of people just came in. Hello, everybody. My name is Saiken MD. I'm a Dr. VTuber, internal medicine doctor in real life. Today I am playing Doctordle because apparently a lot of people just like it when I play Doctordle and yap about different medical things. I started the stream 2.5 hours ago. We are playing Doctordle until I get one wrong. I don't know how long that's gonna take. All right. 57. A 55-year-old woman presents with fatigue, mild chest discomfort, and shortness of breath. I mean, so this could also be anything, right? I mean, fatigue, chest discomfort, shortness of breath. So heart failure is one of those. Any sort of like pulmonary arterial hypertension can do that. Honestly, like a PE can do it too. Let's just say pulmonary embolism. Hello, I'm new here. Hello. What if you need a specific kind of alcohol? I heard some alcoholics drink specific brands of alcohol because of peanut allergies. Okay, well, now you're getting out of my wheelhouse because I am Asian and I flush really badly. So the enzyme. Wait, guys, I'm not supposed to look at chat while I'm doing these questions. Oh my god. All right, so the enzyme that processes alcohol is alcohol dehydrogenase. Or technically it's alcohol dehydrogenase 2, that's the part. And East Asians just like, some of them just like straight up lack that gene. So like my dad is Korean. He's like he could probably drink like a good amount, right? Like my mom is allergic, like period. Like she'll like break out in hives if she has liquor. And I mean, it's mitochondrially inherited, right? So it's like, like you inherit your mitochondria from your mom, right? So it's like if my mom was allergic, like I'm allergic. So like I just like can't tolerate alcohol at all. Like after like 1 or 2 shots, like I will throw up. Like I can drink like half a cocktail or like half a beer and that's like enough to get me buzzed. But like if you put me over like 3 shots or like more than like 2 cocktails, I will throw up. Like it's bad. I'm also like allergic to red wine. Like red wine specifically, like champagne's okay, but like red wine specifically, also like breaking out in hives and stuff on my neck. It's pretty bad. Alcohol dehydrogenase produces acetaldehyde. Yeah, so it's basically like I have a built-in disulfiram. Disulfiram is a medication that we use as like a adverse medication for alcohol use patients, where if they're trying to get them to stop drinking, you give them disulfiram, which inhibits alcohol dehydrogenase, so that they get this really terrible sort of headache like symptom that I get when I drink. So I basically have an inbuilt medication. What's the one where the pericardium is inflamed? Yeah, so I'm gonna say serositis, maybe? Serositis. So, okay. If you're worried about a recent viral illness, you're worried about, I guess maybe like Coxsackie or something, causing myocarditis. If you're worried about lupus, you're worried about serositis, causing a pericardial effusion. Let's see. Is pericardial effusion not enough? Constrictive pericarditis, fibrinous pericarditis. I mean, I guess it could be constrictive pericarditis. I feel sericitis is the right answer. They don't have sericitis on Doctordle. It's a serosa that's inflamed and starts getting edematous, causing your symptoms. But I don't think that's a constrictive pericarditis technically. No. Chest pain is non-pleuritic, and yeah. Wait, it's not. It's non-pleuritic. It is not relieved by leaning forward. Oh wait, so it's not a pericarditis. Blood pressure is mildly low, but pulses are symmetric. Why is it not just the pericarditis? Oh wait, is it tamponade? These are really mild symptoms for tamponade. Okay, got it. Acute pericarditis, myocarditis, yeah. So okay. The thing with lupus is the lupus attacks the serosa surrounding the heart. That serosa gets inflamed, starts becoming edematous, and starts giving off fluid. That amount of fluid is what's causing their symptoms, right? So your heart sits inside a sac called the pericardium, right? And if you have a bunch of fluid buildup in the pericardium, now your heart is basically like free floating in there. And your heart is a pump, which means that it's probably not functioning correctly if it's also being drowned at the same time, right? So that's what cardiac tamponade is. The rest of the clues are saying muffled heart sounds, right? Because instead of just listening to the heart, you're also listening to an extra layer of liquid in between that. JVD is present, though there are no rails or peripheral edema, so it's not a heart pump problem. It's not really backing up into the lungs, but JVD being present means that there's trouble getting flow into the heart in the first place. Chest X-ray shows globular enlarged cardiac silhouette, right? Because normal pulmonary vasculature, you're not having trouble like backing up fluid into the lungs. You have trouble because your heart is like being waterboarded at the same time. So the globular enlarged cardiac silhouette is from the pericardium being full of fluid from the inflammation of the serosa, which is probably caused by the lupus, probably a lupus flare exacerbated by the recent viral illness. This last clue, ECG reveals low voltage QRS complexes and electrical alternans. Electrical alternans is a fun word. So this means that when you do an EKG, because the heart is free floating in the sac and swinging back and forth, one, you're going to have low voltage complexes because it's harder to capture the electrical impulses of the heart like a normal EKG. But because the heart is swinging back and forth, the amplitude? The height of those peaks are going to change based on where the heart is swinging back and forth at that point. So instead of like normal uniform peaks on an EKG, you'll have them going like up and down and up and down and up and down. Wait, could this show with an echo? Yeah, it definitely would show like as a huge, black dot on a parasternal long axis view. You can use that to diagnose an effusion. Obviously, tamponade is basically just like a worse version of an effusion. So yeah, amplitude would be correct. Nice. Wondering if it's the same word root as tampon. I think so. I mean, tamponade just means to like plug something, right? That's what tamponade means as like a verb. So, when you put it like that, it's really scary. Yeah, guys, it was lupus. Guys, it was lupus for once. I mean, the answer wasn't lupus, but the condition was related to lupus. Saiken, for a video idea you should do, could a doctor beat an AI in Doctordle? So that's what I was trying to do when I brought Bree and Hazumi on to play Doctordle with me. Like, can VTubers use the internet to beat me at Doctordle? Bree was interesting, but Hazumi like at least like was googling stuff up, like trying to approach it like how a layperson would probably like, if like your mom ever called you and was like, hey, like I've been bleeding nonstop, like I'm kind of worried about this, like I haven't had my period in 12 years and suddenly it's back, blah blah blah, right? Like these are the kinds of questions that you'd probably like start looking up, to tell them like, oh yeah, I think you should go to a doctor, right? So that was kind of what I was getting at with that stream. I didn't want them to just like say like, okay, go ahead and like use AI, because I mean, I don't know how I feel about making content with like directly showing them using AI stuff, but I mean, none of them use like the Google like auto AI thing, so that was fine. Usually a lurker, but been following for a while and love your content. Started med school late, but it's cool recognizing some of the stuff you cover. Yeah, I mean, for Doctordle, like as long as you get to M2 year, I'm pretty sure like M2, M3, you pretty much know how to answer everything at this point. Like this is a very step 1, step 2 focused game, so it's pretty easy. All right, 65-year-old man with dementia presents with a 2-day history of fever following an elective cholecystectomy. Okay, this is shit that happens in the hospital. All right, so, oh wait, is he in the hospital? 2-day history of fever following an elective cholecystectomy. So you're thinking of post-op fever, right? So it's water, wind, wabscess, walking, wonder drugs. So 2-day history, I mean you could just have an infection, right? Like a hospital acquired infection, some kind of nosocomial infection. 2-day history of fever following an elective cholecystectomy. I mean, what is post-op fever? Is it wind, water, wabscess, or water, wind, wabscess? I think it's wind, water, wabscess. So you're thinking about like urinary tract infection. I don't know why Doctordle specifies that it has to be an E. coli infection. What? Dude, I was so close. All right. Urinary tract infection. So it is wind, water. Wind, water, wabscess, walking, wonder drugs. Those are the 5 W's of post-op fever. I don't remember that much from my surgical rotation, but I remember that much. During the procedure, he had a Foley catheter placed and complains of continued urinary discomfort. I don't get it. How's it not a UTI? It's literally a UTI. He had a Foley placed during the procedure and has had 2 days of fever since then. What the hell? What? Oh, you know what this is? This is Enterococcus, Enterococcus faecalis. That is so stupid. That is so fucking stupid. Because Doctordle only has E. coli UTI. Doctordle only has E. coli UTI as a UTI thing. So for Enterococcus, you have to say enterococcal infection. Okay, Enterococcus faecalis is a gram-positive bacteria that grows in the biliary tree, and it also can grow in the urinary tract. This is really stupid. This is just something that I remember from Sketchy, but that's just like that's where it goes. It's like the Sketchy diagram is like an environmental protest, and it's a bunch of protesters going stop the fees, and they're holding a banner and they're like, do you heart trees? And it's like the U is for urine and the heart is the heart and the trees is the biliary tree. That was stupid. That was crazy. Wabscess, how do you spell that? Yeah, so okay, the 5 W's of post-op fever are wind, so atelectasis, so like your alveoli aren't expanding because you're not breathing enough. Water, which means like UTI. Wabscess, which is just abscess, but you put a W in front of it. Walking, which is supposed to be DVT, and then wonder drugs, which is, I don't fucking know, but it's like drug related, so 2 of them don't even begin with W, but they named it the 5 W's of post-op fever. So that's why it's called the 5 W's. This is why you don't let surgeons name things. All right? Just life lesson to everybody out there. This is why you leave the nomenclature to the internal medicine doctors. All right? And the surgeons are there to cut and operate. Boom. Mic drop. Tell us about sleep apneas. So there are 2 types of sleep apnea. There's OSA, obstructive sleep apnea, and central sleep apnea. Obstructive sleep apnea is what you're going to experience when you physically have something blocking your airway while you're sleeping. So whether because you have gigantic tonsils, which is why a lot of people in America get them removed from their kids, or if you're overweight, you have a large neck circumference and your airway collapses on itself and you're sleeping. These are obstructing your airway, and that's causing you to like not get enough oxygen while you sleep. So that's when you wake up and you don't feel like you got a good rest, probably because you were breathing in carbon dioxide for like 80% of the night or something, right? Like you didn't get enough oxygen in your brain, so you don't feel well rested. Central sleep apnea is usually going to be more of a brain problem, the center that's regulating you to breathe while you're sleeping, and usually is a lot more detailed than just like doing CPAP or giving them a device to breathe through in order to fix that. Shut up and cut, surgeon. Exactly. Just put the gallbladder in the bag, bro. I find it so funny. Do you heart trees? Dude, I will I will show you the Enterococcus sketchy right now. I will show you the Enterococcus sketchy, and you will understand these stupid images that live rent-free in my head, you know, all these years later. All right, it's like an environmental protest. Okay, the banner says, "Do you heart trees?" Okay, they 6.5%, you know, right? It grows in 6.5% saline. All right, it's Enterococcus faecium. That's why it's called Stop the Fees. Okay, they are wearing they're wearing boots because they, oh shit, what do the boots mean? I don't remember. They're wearing boots. This guy is resisting getting in the van because Enterococcus is resistant to vancomycin, okay? And you treat it with the police line, linezolid, and you treat it with this tiger stripe line, tigecycline. Why the fuck do I remember that? I learned this 6 years ago, and these stupid pictures live rent-free in my mind. Now it's gonna bother me. What are the green boots? Enterococcus sketchy green boots. Oh, the green boots are bile resistant. All right, because it's bile resistance. That's why they grow in the biliary tree. Because yeah. Oh my god, that would be a cool poster to hang up, dude. There's so many sketchies that I would hang up. Like who here was saying that there's an M1? Yo, Affy V3. There will be a time in October, either this year or your M2 year, when your school or your class president or whatever is like, yo guys, let's have a sketchy micro themed Halloween party. All right? And you better go to that, and you better dress up as your favorite sketchy, because if you don't, Saiken MD will be judging you. All right? Like, sketchy Halloween parties was like the best part of med school. I know how sad that sounds, but it was like the only time where you have all of these fucking nerds dressed up in their stupid mnemonic costumes, and you get to be like, oh my god, you're Naf-Cillin, Naf for staff. All right, guys, it's almost been 3 hours. I need to get one wrong. I have work tomorrow. I have work in 11 hours. All right, the mother, oh, okay, Pete's question, we're donezo. The mother of a 4-year-old child calls into the clinic reporting of a 4-day history of cough, malaise, and rhinorrhea in her son. Dude, this could be anything. This could be flu. This could be any URI. Yeah, let's go upper respiratory, viral, upper respiratory. They don't have URI. Let's just say flu. Influenza virus. All right, well, he's got a fever. Okay, I would have expected that much. He's tacky. Okay, I would have expected that much too. Go to sleep, saiken. I'm okay. I mean, I don't go in until 11, right? So, I mean, I can still, okay, realistically, I'll probably still stay up for like another 2.5, 3 hours or something, right? Like, I don't need to go to bed immediately. I haven't gotten one wrong yet. It's croup. Does he have a barking cough? Parainfluenza virus, croup. Nope. On examination, he appears ill with red, watery eyes and periorbital swelling. Thank you for the subscription. Hajumi, Eileen, big Saiken fans in chat. Haven't we done this? Have we done this? Wait, have we done this already? I don't remember. Ill with red, watery eyes and periorbital swelling. Oh. Wait, have we done this? Have we done this? Is this the one where it's like, oh, he's unvaccinated? Oh shit, wait, maybe we did do this. No, actually, no. I don't think we've done this before. Because I think I remember like the one that we did before, I think this one was about the mother of the child, and then it was rubella or rubiola, but I think this one, the actual question was like the mother of the child who also says that her child is unvaccinated, had a similar symptom or something. So I think, oh, repeats are possible? I actually didn't know repeats were possible. I think that one was rubella though. This one's rubeola. So rubella is German measles and rubeola is measles. And they're two different viruses, but whatever. You have, but not this case specifically. Oh. Oh no, does that count? Oops. All right. I guess we keep going. 25-year-old woman presents with a firm, irregular breast lump. Phyllodes tumor. She was recently the restrained passenger in a motor vehicle accident. I mean, we were just talking about pancreatitis and trauma being one, so breast fat necrosis, I think, is probably the answer. Yeah. So when a patient is sitting in a car and you're wearing your seatbelt and you suddenly have that immediate trauma to that area, you can actually like cause the fat to basically burst essentially and saponify. And that trauma is enough to basically set off this necrotic reaction where more dying cells are going to chain react and cause more dying cells and everything. So these microcalcifications and these lipid-laden macrophages and necrotic adipose tissue is just more breakdown of breast tissue and the macrophages that are trying to clean the space up. But yeah, fat necrosis from trauma, definitely a real thing. It's essentially the same thing for pancreatitis. You would get the pancreatic fat necrosis from trauma like a seatbelt as well. All right, that one was pretty straightforward. For a firm irregular breast lump, the fact that they give you motor vehicle accident in the second one, I feel like they could have been a lot worse. They could have been a lot ruder with that. All right, a 29-year-old man presents with rectal discomfort and a sensation of incomplete evacuation. Okay. Rectal discomfort and a sensation of incomplete evacuation. I mean, internal hemorrhoids. Internal hemorrhoid is a good one, right? Because if they're pooping and they're feeling it kind of like plopping around in the rectum. Intermittent tenesmus and mild rectal bleeding for the past 2 weeks. I feel like that's still valid for internal hemorrhoid. I feel like because external hemorrhoids are painful and it's discomfort and sensation of incomplete evacuation, right? It's not exactly painful. A lot of people overlook proctitis. That's a good one. Oh, okay, it was proctitis. All right, there we go. The patient reports, I've noticed a slimy or sticky coating on my stool. He denies weight loss, but reports recent receptive anal intercourse without condom use. So, I mean, flexible sigmoidoscopy shows erythematous, friable mucosa limited to the rectum. So it's all, you know, happening in the mucosal layers in that area. It doesn't go any higher, but it's not going any lower. So you're basically just having a local infection. You would probably like, I mean, 29-year-old man. I mean, you could be worried from recent receptive anal intercourse without condom use about things like HPV, right? But I think proctitis is just like a more immediate infection that would pop up in 2 weeks. You wouldn't be worried about like anal cancer or like immediately have to like scope him or something. But I guess they did scope him anyway, so I feel like you can diagnose this without the flexible sigmoidoscopy. Like you don't actually need to do the scope in order to diagnose proctitis. All right, moving on. 76-year-old man presents with persistent back pain and fatigue, progressively worsening over the past several months. Back pain and fatigue. I mean, there's so many things. I don't know, like back pain and fatigue, like degenerative joint disease or something. I mean, he's old, right? Degenerative disc, degenerative joint. They don't have anything. Lumbar disc herniation, maybe. I mean, that's not really pain. It's more like sciatica, but Laboratory studies reveal a hemoglobin hematocrit of 10 and a serum calcium of 12.1. Okay, so now I'm thinking more like multiple myeloma. There we go. All right. So elevated serum calcium, it's one of the crab signs of multiple myeloma. Multiple myeloma is it's a cancer of the B cells in your bloodstream, like the cells that produce antibodies. And basically you're going to have a growth of these cells where they just start producing out a bunch of junk antibodies, and that clogs up your kidneys, causes kidney damage. You're going to have these lesions in your bones, and it's going to spike your calcium levels. And you diagnose this by trying to find a spike of immunoglobulins. So this is what the serum protein electrophoresis, the SPEP, and the UPEP end up doing together. They help you identify which antibody line is being overproduced here. So, yeah. When you're too tired, will you throw intentionally? I feel like I'm not gonna throw intentionally, but I feel like I'll just say that I'm tired. Because I really don't want to continue this challenge onto the next stream. I'm late to stream, don't worry about it, because I show no sign of stopping anytime soon. I will probably get out on a peds question or an OB-GYN question, just knowing my limits. Just wanted to ask, is it possible for me to be a doctor if I faint from seeing blood? I wanted to be a doctor since I was a kid. I mean, like, as a vagal response, I think you can... I mean, with things like exposure therapy or just like therapy in general, I think it's possible. I mean, it depends on like what kind of doctor you want to be, right? Like if you want to be like a family medicine doctor, you probably, or yeah, if you want to be like a psychiatrist, like you'll probably never see blood ever, right? Like if you want to be a trauma surgeon, like, okay, maybe probably not, but yeah. Dog, you better check yourself before you wreck yourself. Shit. Last time you did Doctordle by yourself, you stayed up until 2 a.m. Oh no. Oh no. We will never escape. Could go into anesthesiology. Oh no, dude. Anesthesia, you know, when the ER can't get a traumatic airway because there's like too much blood, you know they page anesthesia, right? So I like emergency medicine and cardiology, so I'm pretty sure that might be a problem. Yeah, I feel like I feel like psychiatry would probably be a good option. Honestly, family medicine, you would still have to do procedures in office too, so you'd still probably see a bunch of blood too. Maybe endocrinology? But you'd still have to do an internal medicine residency to get there. Yeah, I'm pretty sure psychiatry is probably doable. All right, a 7-year-old boy is brought in by his parents due to concerns about school performance. Okay, well, we said we can do repeats, so I'm pretty sure the other school performance question was also ADHD. Okay. His motor development is delayed and he has trouble forming full sentences. Okay. Maybe like trouble forming full sentences and stuff, you could think about like the autism spectrum disorders, but motor development delayed is actually, that one's kind of bad. Now, I mean, motor development delay, well, motor development delay is its own host of disorders, but motor development delay and trouble forming full sentences is more of like a global like intellectual disability thing. Like now you're thinking like, I don't know, like Edwards syndrome, you know, Patau syndrome, like all these like trisomies from like med school that you never think about. Faye, thank you for the raid. What if it's dyslexia? He can't read right. I mean, dyslexia wouldn't cause motor developmental delay, right? Like motor development being delayed at 7 means like he's probably not able to like run around or something, or like stand up unassisted or something, right? So that's Landau Kleffner. I don't even know what that is. Man, I'm not even supposed to be looking at chat. Oh, jeez. Are we ending the stream here, guys? Oh, crap. I have no... All right, let's... I don't know. Down syndrome? Physical exam reveals no dysmorphic features. Ah, oh, god damn it. Okay, so it's not Down syndrome. It's not Edwards syndrome. It's not Patau syndrome. It's not any of the other things. I mean, it's not... It's not Angelman. It's not Prader-Willi. Physical exam reveals no dysmorphic features. Like, what? What intellectual disability doesn't have dysmorphic features, right? Like, they all have some, like, physical exam sign. I mean, I guess I could say autism. I really don't think it's autism, though. I mean, it's the motor development thing that's... Teachers note he requires significant support to understand basic concepts and instructions. Looks like I'm going to bed, gang. Dude, like dysmorphic features. Like even things like fetal alcohol syndrome would have dysmorphic features, right? Like a lot of these genetic conditions usually come with like almost a pathognomonic dysmorphic feature. Like what? Is just general like intellectual disability an answer? Is it this one maybe? Oh wow, okay. Yeah, wow. I almost did not get that one. I didn't realize that intellectual disability could just be like guessed by itself. That's crazy. That's yeah, so like I was thinking like along the lines of trisomies here, right? Because the dysmorphic feature thing, and then genetic testing reveals no identifiable chromosomal abnormalities. But I mean, I guess, right? Because most identifiable chromosomal abnormalities lead to syndromes that have dysmorphic facial features, right? So I was like, how do you get an intellectual disability without a chromosomal abnormality? So I guess it's just intellectual disability. I don't know. Ooh, that was rough. Saiken hates children. Yeah. I'm not legally allowed to treat patients under 18. Like I don't do that. That's not me. Oh, people were thinking like medical Sanfilippo. Oh my god, Duchenne, yeah, but like that would have features, right? I'm pretty sure Sanfilippo would also have features, right? They would have like yeah, it's like the face, like the coarse facial features with thick, broad eyebrows. Like I remember that. I don't remember a lot of lysosomal storage disorders, but I remember Sanfilippo. Weren't we talking about lysosomal storage disorders earlier? Was I talking about like Niemann-Pick disorders? I bet on it before no dysmorphic features popped up. Yeah, that was dang. That wasn't like a hard question. That was just like, what do they want from me? It was like the guy who comes in and he has no complaints. I'm like, why are you here? Why are you here? Hey, so again, I'll donate 50 subs if you go to bed right now. Joking, of course. Tempting. All right. 35-year-old fitness instructor presents with progressive fatigue, headache, muscle weakness, and nausea. So, I mean, we were just talking about it. I'm not sure if, like, progressive fatigue would really be something like that, but I mean, like, rhabdomyolysis. What else do we got? All right, well, now I'm looking at chat because I got a raid. Moo Merrily, thanks for the raid. Hello. What's up, everybody? My name is Saiken MD. I am a Dr. VTuber, internal medicine doctor. I am playing Doctordle, which is like Wordle for different diagnostic conditions, but I am streaming until I get one wrong, and we've done like... How many of these have we done? We've done so many. We've done like... I think we started like 30-something, so we've done like 30 of these, and I still haven't got one wrong. All right, so 35-year-old fitness instructor presents with progressive fatigue, headache, muscle weakness, and nausea. If they have McArdle syndrome, that'd be so funny. Dude, what are the odds that I talk about this on stream and it's the word? Oh, fuck. All right. Medical history includes bipolar disorder, and she takes her prescribed medications. Okay, so when they dog whistle bipolar disorder, that usually means they're talking about lithium, right? And lithium can cause diabetes insipidus. So nephrogenic diabetes insipidus. No, it's not. Okay, well, on physical exam, her vital signs are normal, mucous membranes are moist, and there's no peripheral edema. Huh. See, if this were a board question, it would be very nice to me, and it would start giving me the serum osmolality and the urine osmolality, and I would be able to actually do the thing that I do, right? Remember the AAFP hyponatremia diagram? And you go through, you calculate their tonicity, and then you calculate their volume status, and you figure out which hyponatremia it is. So if it's not nephrogenic DI, it's some kind of, I think it's some kind of hyponatremia, like SIADH. Let's see. All right, you know what? Let's just say SIADH, because it's like, now I really wish I was doing a board question so that I could. Okay, now they give me this shit. God damn it. Lab studies show serum sodium of 135, so she is hyponatremic, serum osms of 280, and urine osms of 120. Blood glucose and calcium levels are normal. So if you're following the whole ass AAFP diagram, I think all of these being normal is actually trying to tell you that it's not a kidney problem at all. And I think the answer is psychogenic polydipsia, which means that they are just drinking water because they feel like it, because they're a fitness instructor, and that has nothing to do with their bipolar disorder or the fact that they might be on bipolar medications, but it's the fact that they drink 6 to 8 liters of water daily for the past several years because they're a fitness instructor and they're super fit, and they probably think drinking water is the best answer to everything, but drinking water can lead to hyponatremia, and hyponatremia can be fatal. Yay. Oh my god. Oh, somebody said primary polydipsia. Okay. Yeah, some people were on the right track. Yeah. Time would pass faster if this was a boards question. Yeah, because I would have this information from the start. They wouldn't tease me like this. I hate Doctordle. Can we go back to boards? The people wanted Doctordle. Have you screened for depression though? Oh shit, my bad. Well, they already have bipolar disorder. Is it true that there's a water OCD? I mean, I guess psychogenic polydipsia is kind of like a water OCD, right? It's like they think they need to be drinking a lot more water, and they drink water because they think that they're thirsty, but all it's really doing is just making their solute level in their blood worse. This is, I think there was a pretty infamous case, like I think it was in Australia or something. This is like in 2006, right? It's when like the Wii came out. And there was like a radio show, and it had a contest called like Hold Your Wii for a Wii, and it like made the participants drink like 4 or 5 gallons of water and like try to like not piss, right? And it's like one of the ladies ended up dying from that because they had like a seizure from hyponatremia because they just diluted their blood so much from that. But yeah, on this one, it says a water deprivation test demonstrates intact ability to concentrate urine with normal vasopressin levels. So this is when you keep the patient in the office and you deprive them from drinking 6 to 8 liters of water daily. Can their kidneys actually concentrate urine appropriately and respond to the hormone that tells them to do that? And for this patient, yes, it was. So the problem is that they're just drinking more water because they just like feel like it. I had a hyponatremia patient who danced for hours in a high heat environment, drank a lot of water, and started a seizure. Yeah, so that's why, you know, for athletes and stuff, they tell you to drink things with solute. So that's why like Gatorade was invented, right? Because you need your electrolytes just as much as you need the water. So should have told us that she pees 5 to 7 times a day. The first question, devious. How do you treat this? I mean, you treat it with water restriction. So I mean, if it is truly psychogenic, then they need therapy. Like, I don't think any other like medication is going to do it for them, other than just like trying to overcome that primary psychogenic disturbance where they think that they have to drink so much water a day. To stretch out the stream, tell us about gastroesophageal reflux disease. Gastroesophageal reflux disease. So it's, you know, GERD, when you get like backsplashes of stomach acid from, you know, your stomach hitting into your esophagus. Generally, you treat this with PPIs, which are proton pump inhibitors, or H2 receptor blockers, which block the histamine 2 system in your stomach. These go in different ways to prevent your stomach from making more acid. So if you don't respond to one class, like proton pump inhibitors, then H2 antagonists are a totally valid one too, because they basically will have the same end effect in the pipeline. All right. Oh wait, this is the one that we just did. Okay. Doctor, can my patient get esophageal cancer from GERD? Yeah. So, wait, you spelled esophageal with an O, but you spelled GERD with an E? Didn't we talk about this on stream one time? That like I thought like people in the UK that spell esophagus with an O call GERD gourd because it's GORD. Anyway, yes, like with enough like reflux and stuff, you can get like esophageal remodeling, you know, in the esophagus. That's called Barrett's esophagus, right? When your squamous epithelium becomes columnar epithelium, and that you can get esophageal cancer from that metaplasia. Jaquello redeemed a hot fire emblem take. I gave so many hot takes already. Hot fire emblem take. Fire Emblem Thracia 776 is not hard. You just need to be better. If you want to play a hard version of Thracia 776, there is a hack out there called Super Thracia, and Super Thracia has true fog of war, where you're actually just in straight up fucking darkness. That is a fun game. Is the answer for this Doctordle actually GERD? Wait, is it? Okay, hang on. I haven't even read the question yet. All right. A 35-year-old woman presents with painful swallowing and retrosternal discomfort. You wouldn't really get painful swallowing from GERD, though. Painful swallowing makes you think more of things like not, or achalasia maybe? No, it's a painful swallowing is more like in the upper, like oropharyngeal level, like tonsillar abscess, right? Like something like more high up. I don't think it's tonsillar abscess though, because usually, what's the one that's not paratonsillar abscess? It's like another tonsil thing, no? Ah, crap. Because usually with tonsillar abscess, you're worried more about an infection, so they usually present with like things like fever and stuff. Maybe they just have like pharyngitis. Yeah, maybe. But again, usually you present with like more than just pain. Oh, but she does have fevers and fatigue. I feel like pharyngitis was a good one. All right, peritonsillar abscess. When are they going to show me her tonsils? Show me your tonsils. All right. Physical exam is notable for white creamy patches on the tongue that can be scraped away. Okay, so that's pretty much just saying it's candidiasis. So it's esophageal candidiasis. God damn it, yeah. So so Candida is a fungus, all right, and you get overgrowth of Candida when you have a bad immune system that can't control the spread of the fungus. So clue number 5 says her past medical history is significant for poorly controlled HIV. So when you don't have the immune system that can fight off the fungus is going to grow, and it's growing past the mouth into the oropharynx into the esophagus. When it's saying physical exam is notable for white creamy patches on the tongue that can be scraped away, this is to differentiate it from other things like leukoplakia or like a cancer that gives white creamy patches on the tongue that you can't scrape away. But yeah, so oral fluconazole is a good one. Nystatin, swish and spit is also a good one. But basically, it's the overgrowth of the Candida infection that's causing the patient's symptoms here. Should screen her for PJP2 since she has retrosternal discomfort? That would be like a board question. This is Doctordle. We're chilling. Doctordle to brush my teeth and then fall asleep too. Hell yeah. I triggered him on the O spelling. Yeah, it's weird. Do you spell edema with an O? Actually, you probably don't even call it edema. You call it dropsy. Oh my god. It's late. We gotta keep going, guys. Oh my god. All right. 27-year-old man presents with fatigue, shortness of breath, and hemoptysis over the past 2 weeks. All right, so he's coughing up blood for 2 weeks. I mean, this one could very also be TB. I mean, could be Mac. On exam, he is pale, mildly tachypnic with bibasilar crackles heard on lung auscultation. Mac? Avium? Oh, they don't have it. Complex? Oh, crap, they don't have it. Hemoptysis. Aspergillus, right? What's the invasive? No, not the invasive, the allergic. ABPA, allergic bronchopulmonary aspergillosis. Yeah. Yeah, that's a thing. No? Okay. I guess it's not a thing. Laboratory testing reveals anemia and elevated creatinine. Okay, so he's got low red blood cells and a kidney problem on top of all this, which, you know, could just be a nutritional deficiency and the fact that he's not drinking water. I mean, this could be a lot of things. So fatigue, shortness of breath, hemoptysis, anemia, and elevated creatinine. Oh, wait, isn't there, oh god, there's, which one is it? It's one of the vasculite, it's not Wegener's. So Wegener's is nose, lung, and kidney, but what's the one that's just lungs and kidney? It's the P-ANCO one, microscopic polyangiitis, there we go. Microscopic polyangiitis. Damn, Fuck. All right, wait. Chest X-ray shows patchy bilateral alveolar infiltrates. Well, I mean, if it's not microscopic polyangiitis, then I guess it could be Wegener's, right? So granulomatose. So it's nose, lung, kidney. Maybe they just didn't give us the nose symptoms. Oh man, it could be Churg-Strauss also. Well, that depends if they give us eosinophils or not. Oh man, I feel like I need more information. I feel like I'm on the right track. Because it's lung and kidney, right? Fuck. Your analysis demonstrates hematuria and proteinuria. And then is the last one gonna be like, there are tons of eosinophils in the... There are a bajillion eosinophils in the urinalysis. No? Immunofluorescence detects linear IgG deposition along the glomerular basement. Okay, so this is Goodpasture syndrome. If it's not Goodpasture syndrome, then I actually get to end stream here, which is fine. But I'm pretty sure glomerular basement membrane and lung and kidney involvement is Goodpasture syndrome. Oh no, we still keep going! All right, that one was the first one to take me to 6. That was I got Doctordle 66 in 6 guesses, guys. Let me sleep. Let me sleep. Guys, you are free to go to sleep. You are free to go to sleep. It's Goodpasture. You're Goodpasture. Yeah. Oh my god. That one wasn't hard. It was just like they didn't give me enough information, right? Like if like they just gave me the urinalysis or something different, like god damn it. I left for a long time. Wow, you're doing great. Yeah, let's. So I have to skip 6-7 because I did 6-7 with Bree already. So close to sleep, but the professional in you could never. Yeah, I'm too good. So we started at 34, right? We started here and we're all the way at 66. So I did 22 of them. So we did 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77. I don't even remember doing these, but all right, so I guess we go to 78. Yeah, I have like a bunch of random ones up here. So like I have like some in the 200s already done. I have like 280 to 290 already done. I have 346 already done. So I guess we just skip to 78. 58-year-old woman presents with non-specific pelvic discomfort. All right, shit, dude. This could be so many things. I told you I was gonna go out on a gynecology question. All right, so I guess we can start with ovarian cyst, maybe. Oh, fuck. A firm adnexal mass is palpated on pelvic examination. That is literally how all of the other gynecology ovarian cyst questions started. Ovarian, well, if it's not a corpus luteal cyst, maybe it's a thecalutean cyst. Oh my god. Pelvic ultrasound demonstrates a small, solid hypoechoic ovarian lesion. Oh my god. All right, well, if it's not a corpus luteal cyst and it's not a thecalutean cyst, then maybe it's an ovarian follicular cyst. God damn it, what the fuck? How many different ovarian cysts are there? She denies weight loss, early satiety, or bloating. Okay, so it's a cyst. It's not a cancer. All right, it's probably not a tubo-ovarian abscess because she's not coming in with fever, so it doesn't look like a sign of infection. Serous cystadenoma, mucinous cystadenoma, dermoid cyst. Oh my god, mature cystic teratoma. Oh my god, it could be any of these. I think we already did serous cystadenoma for one, right? Okay, so dermoid cyst and mature cystic teratoma are basically the same thing, right? Like, isn't a teratoma a type of dermoid cyst? Oh god, I don't know any of this. Mucinous cystadenoma. Oh my, I don't know, man. Oh god, it's a cyst. Oh fuck me. Dermoid cyst. Histology reveals nests of epithelial cells with grooved coffee bean nuclei. I have no idea what that means. I feel like if you're a pathologist or an OB-GYN, like, you probably instantly know what this means. I have no fucking clue what this is, guys. Coffee bean nuclei? Cyst. I guess serous cystadenoma or mucinous cystadenoma wouldn't have coffee bean nuclei. I feel like a mature teratoma does not have coffee bean nuclei. Dude, what the fuck? What is coffee bean nuclei? I'm thinking like orphan Annie nuclei, like Reed Sternberg cells, owl's eye nuclei. I don't know. I genuinely don't know what coffee bean nuclei is. Well, it's nests of epithelial cells. Is nests of epithelial cells going to be a cancer? Why is there no cancer? Ovarian cancer. Why carcinoma? All right, here we go. Fuck me. Choriocarcinoma? No, it's an ovarian lesion. Mucinous carcinoma, serous carcinoma, renal cell, mucoepidermoid carcinoma. I don't know. I think it's time for bed, guys. I don't have a good answer. Mucoepidermoid, right? Because it's got epithelial cells. Mucoepidermoid makes sense. These cells resemble transitional epithelium, and the excised tumor demonstrates benign features. What? So it's not a it's benign. So it's what? But transitional epithelium should not exist in the ovary. So this is a tumor. It's metaplasia turning the ovarian tissue into a transitional epithelial tissue. Transitional epithelium is like the bladder, right? So it's something that can stretch, and the cells in there can like stretch and squash. Which, you know, for the bladder, because it expands and, you know, retracts as you have more urine and expel urine, it's fine. But like, obviously, you don't want your ovary cells turning into transitional epithelium. I mean, it's not cancer, it's metaplasia, but it's like is ovarian metaplasia an answer? Oh my god. All right, I think it's donezo. I think we lost. Shit, I don't even know what this is. Like, again, I'm sure if you're a pathologist or OB-GYN, you see coffee bean nuclei and transitional epithelium, and that just like instantly means something to you. But this is meaningless to me. All right, mucoepidermoid. What was the other one? Serous cystadenoma. Serous, so it's transitional epithelium. I don't fucking know. Game over. The diagnosis was Brenner tumor. What the fuck is a Brenner tumor? I don't know what this is. A Brenner tumor is an uncommon, predominantly benign type of ovarian surface stromal tumor. Okay, fine. Give me some histology. All right, well, so nests of epithelial cells with bean nuclei. Oh my god. Well, I mean, when you put it like that, yeah, it makes sense. God damn it. Go to bed, saiken. Bedtime for you. Like 3 people said Brenner tumor. How do you guys know what a Brenner tumor is? Well, deadass, I don't even remember learning this in med school. What? Coffee bean nuclei? Are you kidding me? Benign but sometimes malignant ovarian Brenner tumor named after Fitz Brenner. Some of the nuclei have a longitudinal groove similar to the groove found in a coffee bean. I'm a pathologist. God damn it, Lucy. It was good while it lasted. We tried. We tried. We were finally defeated. No. All right, honestly, we'd been going for like 3.5 hours, so I was kind of ready. I was kind of ready to clock out anyway. I did say at the beginning, if I go out, it's going to be to a gyne question. And lo and behold, it's a gyne question. So this just really, you know, hammers home the point. Stay in your fucking lane. I'll donate 100 subs if you stay awake. Oh my god. I had a small one found during an abdominal surgery. It was out of the ordinary for many reasons, but that was funny. I mean, it's out of the ordinary because it's a benign stromal tumor that also is like made of transitional epithelium. So it's a metaplasia, but it's benign. It's crazy. Oh, everybody said goodnight. Thanks for the cool stream. No, I joined exactly as you're finishing up. I'm sorry. All right. So I'm back at the hospital tomorrow. I will be working for the rest of the week. I will try to stream, probably not until next week. I'm probably not going to have time to. Maybe like next Friday, next Saturday. I do have things I need to record. I also need to work on my presentation for Offkai. Like, I need to work on my panel PowerPoint presentation, because Offkai is going to be the week after that, so that'll be fun. I forget it's Monday right now. Yeah, I work Tuesday to Tuesday, so like my sleep schedule and my on-off schedule depends. Like, it's a gacha game and my weekly resets. All right, thanks everybody for stopping by. Thanks for the raids. Thanks for hanging out with me, watching me crash out over Brenner tumors. I will probably never forget what a Brenner tumor is. Will it ever be relevant to me as internal medicine doctor? No. Time to pick up a Robbins and Coltrane. Dude, I threw away my Robbins after med school. I hate Robbins. I kept Pathoma for the good memories. I kept my Grays. I kept my Grays because it was. I mean, Grays and I think Pathoma are pretty much iconic. Like, Pathoma is like our version of Robbins. I feel like we had a big copy of Big Robbins in our resident lounge. But I don't think I opened that since my intern year. All right. Thank you, everybody. I appreciate you all. Let me go find somebody to raid on Twitch real quick. I think we sent a raid to Sayu last time, I think, right? Who's live right? Guys, Double Lift is live right now. Guys, we can go raid Double Lift. Double Lift is so cool. All right, we are going to go raid Ashton Martin. She is doing a recap of her time at AX. If you are subbed, you can use the raid message with all the silly emotes because it looks very silly. If you're on YouTube, I'm sorry, I can't raid for you guys. I have the numbers, I just don't follow most of my friends on YouTube, so I don't know who's live or not. All right, but yeah, I'll probably be next online maybe like another week and a half or something. But you know, videos still come out twice a week. We are still finishing editing the other board review videos. The Doctordle video from this stream will probably come out in like 2 weeks or so. So y'all still got content to keep you over. All right. Thanks everyone for coming by. I hope you have a good rest of your week. Drink water, take your medications as directed, and stay healthy. Good night.